Good. Yeah. Would you go with something for your there? That's not their bar. For how long you guys? Well, I mean, I get it. Yeah, we just. That's sort of fun. It was really, really. So. Yeah, I've been seeing. Yeah. Okay, well, even, oh.
Oh, it's this way. I'm sorry. And she said, go around the left and talk to you. Right.
Yeah, no kidding. Yeah. Okay. Yeah. Yeah, way back. Oh, my God. Here's, so, yeah, we have this one. Oh.
Just asking.
That's. Better. And they, it's. Xmas Day. This, I'm gonna call back to that, say, well, six. That would be. Well. I was lucky. Well, we're gonna do it then. Yeah, because.
Is she,
Yeah, exactly. Yeah. Yeah. I agree. Yeah, for the. We got a lot of very excited. Kind of a bunch of so if you already That would be great. Everything is going through WCJ. Orange state over. Kind of got on the front end. So, it's a little bit. Yeah. Yeah.
You just they still have.
So. That's sort of Japanese are going around patient. So, brain, yeah, you put that together. I think it's just especially like you. Oh, that's it. But I also think we have, yeah, you're it's not all the pianos. So that's sort of. Some point, guess what time of the night, but, like, yeah, maybe get Dr. Hall for you. Yeah, I'll go for it. Yeah. Travis and I played the other day. Oh, yeah. Oh, nice course. Yeah, the, another was, St. John's Golf Country. Yeah, no, at St. John's. Yeah, fantastic. Thank you. Oh.
Okay. That's what I was Yeah.
No. There's a.
She was around like 6:30.
Yes.
It's 6 o'clock at night, so 6:30. There's 6 o'clock, but we're not going to. Then, like Tuesdays, they had it and then they stopped. And now they're having Mondays outside. The grass is wet.
Yeah.
So, they're the same speed. Yeah. They have say they didn't know that that was. I don't know if something was scary for that chance. But I haven't seen it happen. Thank you, Bonnie. Yeah. But that's
That's no fun. Yeah.
Just forget my ideas. I have to say. Right. But it was Lois. No, because I'm thinking of the influence. Or they got down. Or that too. But that's what I was thinking. Like, I don't want to do that. So, that's very much. Fantastic. It's
Don't send the images for reading. It's that our infection only the day has dropped with the new protocol. He was asking us to something in some direction. Before we sign, let me pull up the ultimate anyway. Yeah. Just gonna see what is in there, but it looks like it's better. Right? Thank you. There we go. Everyone, microphone works best. Morning, everybody. The resistance, the soldiers to be here the first thing in the morning. It's Friday, guys. And I'm not a call. Look at that smile. Thank you. You guys know I need it, right? Thank you. We can celebrate Nima Sobajo and Keda, they're not in the room, so they're probably not listening to the stream anyway. So I'm happy that somebody else is taking care of the house. We have a very, very nice program this morning and this afternoon. We're gonna flip the second talk to the first. So the first speaker is Dr. Mark Rebo. Mark is a dear friend from Spain, specifically Barcelona, and does a phenomenal job in stroke neurology, stroke intervention. He's going to talk to us about neuroprotection for acute stroke. What is the future? He was planning to be with us at least on the Zoom live for circumstance he cannot be with us, but he sent us the report to talk. So we're gonna watch his talk together, and then we'll answer questions to the best of our ability. And then after that, we have Dr. Nima follow with his talk, and then after that, we have Dr. Lopez from Chicago with some updates on optical iris tomography. Very exciting. We have Jeff here from Sprite representing the sponsor. Will be one of the sites for their clinical trials starting hopefully sooner this year. We're very, very excited to change this game again. So with that, let's go ahead and play Dr. Rebo, and we'll go from there.
Because I will be traveling at the time of the talk, I had to record it, so I cannot be with you even remotely. But I prepared this presentation about neuroprotection. I hope you like it. And I put this first slide because many people consider the first neuroprotectant drug as the golden egg hen. Anyway, and while ago, in 2008, we would see these big headlines on stroke journal. Neuroprotection doesn't work. No tissue salvage without reperfusion. In fact, that was exactly after the same one and same two trials. The same one was very promising. The same two unfortunately failed, in which many thousands of patients were included, but they failed to show effect. And most probably at the time, investigators blamed the fact that yes, maybe the drug had some kind of slowing the recruitment of infarct, but if reperfusion did not occur finally, then the tissue would end up, the fate of the tissue would end up being the same, and with the necrosis and infarct. So we started to believe that in order to show a neuroprotectant effect, we need to combine it with reperfusion. And it's not until 2015 that we had sustained reperfusion in most of our patients when we approved endovascular treatment. So at that point, we finally had a reversible ischemia model, like we have recognized. There is an ischemia, you can give your neuroprotector, and you are pretty sure 90% of the times, few hours later, this vessel is going to be recanalized, and you will have, therefore, a reversed ischemia model in humans. So this is why most of us are shifting towards testing neuroprotectants in patients that will receive endovascular treatment. So here's a long list published in 2006 only of trials or drugs that failed. You can see that most of them were neutral, and some of them were even negative. So I'm going to show you an example next. So typically, this is what occurred. You were following your testing first in mice, or then in primates, or more of this kind of animals. You see here is a very promising trial, still very in primates, in which you can see that nimodipine has better effects in general than the primates that receive the control or the placebo, these monkeys. So after this promising, and look how many of these, this is very difficult to achieve today, perform a trial with so many monkeys, right? But they showed that in general, controls had worse outcomes. Then they switched to humans. And here, with 220 patients per arm, you can see that there is absolutely no effect of nimodipine in neuroprotecting stroke patients. So this is typical story, one time after the other, drugs used in that sense. And even, this is also a very famous example, Selfotel was another drug. It was an NMDA antagonist, and the DSMB had to stop the trial during recruitment because it became obvious that outcomes with the active drug, with Selfotel, were much worse than with placebo. So it's not that we were not helping patients, we were harming them, or they were harming them with this drug. So, yeah, curious example, right? Anyway, if you go to PubMed or you type neuroprotection stroke, you will see that every week you have a long list of new publications. So this is a very hot topic. And you can see all the names of these different drugs that potentially or supposedly have a neuroprotective effect. So again, everybody's trying to look for this molecule that will slow down and prevent infarct growth during the acute phase, subacute phase, sometimes even in the chronic. So the concept, the most believed concept today is that we can show it in the following slides. So here's the typical representation of slow progressor, intermediate progressor, and fast progressor during the first hours of the stroke, and how the infarct volume growth is going to stop when you achieve reperfusion, right? So the idea is that at some point, and the earlier as possible, you administer the drug, and that will freeze the infarct growth during a few hours. It will not continue to grow. And then when you finally recanalize the patients, you're going to see a difference in the final infarct size between those patients that were received the drug and those who received the placebo and did not receive anything. So in order to make this neuroprotectant effect bigger as possible, we need to find strategies and enrich our population. First idea is that you need probably to give neuroprotection as early as possible. And again, it will depend on the mechanism of action, but in general, it's going to be easier to find an effect if you administrate your neuroprotectant earlier. So you're going to slow progression in these patients that receive the drug earlier. And there's going to be a bigger delta, a bigger difference in the final infarct between those who received and did not receive the drug. Eventually, or potentially, or the best option would be to go with neuroprotection in the ambulance. The second option is to try to avoid, at least in your trial, in which you want to show an effect, those who you call the slow progressor. Since the infarct is going to go very slowly, at the end of the day, the difference between those who receive and not receive the drug is going to be minimal. So you need to try to exclude those, and this you can do many times with imaging on admission. If you see good profile of collaterals, either on CPA or on CPP, and then you don't want this patient to be in your trial. And the difference in the clinical outcome with placebo is going to be minimal, because anyway, they're going to have a good outcome in general. So you try to avoid slow progressors. You try to give your neuroprotection as early as possible. But what happens is more and more, we're able to streamline our workflows. We give endovascular treatment earlier, and the recanalization, of course, earlier. So even if we advance neuroprotection, also because we are able to improve our metrics in treatment, at the end, we are playing against neuroprotective trial. So ideally, again, while we are advancing recanalization, we potentially need to find ways to give this neuroprotectant earlier, as early as possible. And the best solution would be to give it in the pre-hospital setting. However, the difficulties, think about the difficulties of EMS to give a neuroprotectant, to ask for the informed consent, to evaluate well the inclusion and exclusion criteria. In these EMS paramedics, they are not seeing stroke patients 10 times per day, not even 10 times per week. And probably most of them are seeing an acute stroke once per week, once per month. And so they deal with many different diseases. So if they are not stroke experts and they don't, there is usually no time to explain to family members that are in shock in this moment, the pros and cons and the informed consent to get into this trial. So it's very difficult to do that at the pre-hospital setting, but it would be ideal. And for the same reasons, it's going to be easier to start trials, such complex trials usually that require blood sampling, that require all what I just mentioned, to do that in a primary stroke center. The stroke, where again, they don't have the capacity, they don't have the support of research team and research coordinators. They don't have all the logistics that allow blood sampling, spinning, and again, they see many kinds of patients, and stroke is a minority. The patient that a physician in the ER sees in the primary stroke center. Really, it will be fantastic to do that as early as possible, but we need to balance between ideal and possible. Here, you see what happens typically in urban, suburban, rural areas in terms of time. The stroke happens here at time 0, and patient gets to the first hospital. They go directly to the primary stroke center or to the comprehensive stroke center, or what happens when they get to the comprehensive after stopping at primary and the door in, door out time at the primary, and they get to the comprehensive. So ideally, you need to give neuroprotection, or this is what you can do a few minutes after arrival to the comprehensive stroke center. But if you could give it at the primary, you would gain a lot of neuroprotection time. Here, this is a logarithmic scale, but it will be, especially in rural areas, that would be ideal to give in the primary stroke center on neuroprotectant and then send to the comprehensive, where counting for the door in, door out time, they will receive thrombectomy here. So you have a long elapsed time in which the neuroprotectant drug will be doing its effect as compared to placebo. So the worst solution is to give it to transfer type patients at the comprehensive stroke center. So the stroke grew already, and then you are gonna give the neuroprotectant, and a few minutes later you're gonna reperfuse. So ideally, the best scenario again would be to give it as soon as the ambulance gets on the scene, and you can start. Yeah, and if you could give it at the primary stroke centers, yes, of course, this data is not looking good. Door in, door out time at primary stroke centers of more than 2 hours looks very bad. But if during this time you gave a neuroprotectant, so it will be doing an effect here already. So, but again, it's not going to be possible, probably most of the time, to do such a complex clinical trial in out of comprehensive stroke centers. But the good news is that in Los Angeles, the Cerebrovascular was able to run such a trial, and that was the FASTMAN trial, in which the idea was to give a neuroprotectant, magnesium, IV magnesium, by paramedics on the scene as soon as they identify the candidate in the field. The bad news is that magnesium did not have a neuroprotectant effect. However, what they were able to show, and this is very nice, they were able to show that they could recruit all this number of patients with median symptoms to drug administration time of only 45 minutes. So within 45 minutes from symptom onset, paramedics came to the scene, evaluated the patients, obtained somehow an informed consent, and they started their medication right away. And this is remarkable and unprecedented, and hopefully we can replicate it with a drug that works. But it's really nice to know that this may be possible. And there's another very famous trial, the Escape NA1, that we're going to talk later. But if you compare the time under which the patient is under neuroprotection, when the drug was given at the pre-hospital setting, as compared to the in-hospital, so you gain all this time of neuroprotection before you achieve reperfusion. So this kind of design is much more likely to end up showing positive results, and because if you receive the drug, you will be protected all this time. If you receive placebo, you will not. And here you will be able to find a difference in final lymph node or in clinical outcomes, 24, 1 week, 3 months, whatever you you decide on the trial. So it leads us to the point that we defined not the golden hour that was defined for TPA, for IV TPA, but the platinum 30 minutes. Those would be this initial 30 minutes in which, in some trials, they were able to already to administer the neuroprotectant medication. Remember, if your neuroprotectant shows in that it does not, at least it does not harm patients with an intracranial hemorrhage or a stroke mimic, you don't really need a CT to administer the drug. You just give it to any stroke suspicion at the pre-hospital level. If it's an ischemic stroke, it will help. It is possible that it will also help the patient because there are very many shared mechanisms of harm with ischemic and hemorrhagic stroke. But at least if it doesn't hurt the hemorrhages, you can safely give it at the pre-hospital level, and you don't need to perform a CT scan at the hospital. It is not like IV TPA. Anyway, I was involved in this project, and I'm gonna show it as an example. Targets is developing a neuroprotectant drug, and we went through all the phases from conceptual phases, which a neuroprotectant can work interfering with exocytocity that happens in the first minutes after ischemic injury, or inflammation, or apoptosis. So it depends on where your drug works, and it will make more sense to give it earlier or later. But in general, as a general concept, the earlier you give it, and then you can repeat doses if needed, the better, right? So Aptol, this neuroprotectant, or potential neuroprotectant, works on inflammation. And we decided that we want to design a trial in which we give it as early as possible in the interval of 2, 3, 4 hours, less than 6 hours from symptoms onset. So Aptol is the exact mechanism does not really matter, but it is an anti-inflammation that stops the inflammation cascade very high. So it then will hamper many mechanisms of inflammation that will happen downstream, right? And they showed in animal models that when patients do not have this toll-like TLR4 receptor, the infarcts are so. This is very common. How many molecules have shown in the past to slow infarcts in rats, mice, and the bigger animals. So humans are able to slow stroke progression in animals. It seems super easy. Many drugs do that, but there's no way that we can show this or translate this beneficial effect into humans. In any case, when these rats do not have a TLR4, the rate of hemorrhagic transformation after TPA is also minimal as compared to normal rats, right? As I was saying, the TLR is high in the cascade of inflammation, and Aptol is going to block TLR4. Aptol is a new family of drug development. It's a sequence of nucleotides like DNA, but it's a single strain, and you can modify or tailor this sequence in order to get the shape, the molecule that will target your basically your target. So here we're targeting TLR4 receptor, and Aptol will have this effect by blocking TLR4. As you can see here. So with aptamers, the nice thing is that you create many candidates with similar structures, and then you can test them in your lab, and you can choose your ideal candidate according to the half-life, according to the magnitude of the effect that you're looking for. So you look for a candidate selection, and then you take your winner and you follow the right? So yeah, after stops here the inflammation cascade, and the effects that are seen, I will show you in the animals. So once you have your candidate, you produce enough quantity to be able to continue developing your experiments, and you have your preclinical phase with animals and your clinical phase in which you jump to humans, if hopefully. So in humans, we've seen well, you determine what is the half-life of this drug in rats, monkeys, and you try to show clinical effects. And the safety, of course, you load animals with higher and higher doses, and you try to look for potential side effects, infections, bleedings, hematologic problems, whatever. With an anti-inflammation drug, you would maybe expect, or you want to look for if this drug does not induce more infections, something that is very common with severe strokes. So we were particularly concerned about infections, either in animal, sorry, in humans, with this drug. So what we find is after in permanent MC occlusion models in rats. So you occlude the artery, you give the actor, and you can see first that in blood biomarkers related with inflammation, the drug leads to lower levels in general. So you're lowering your inflammatory response after ischemic injury. Then you go to infarct volume. And then again, you confirm that the animals that receive the active drug, as compared to the vehicle, to the placebo, and they present smaller infarcts, as you can see here. And then you can somehow measure the functional outcome. So you try to find placebo. And finally, you can find, because in the lab, you can do whatever you want. I mean, you can give the drug at 10, 2 hours, 6 hours precisely. This is something that is impossible to do in humans, right? But you determine after a perfusion or before a perfusion the timing in which you give the drug, and you can see when is the better time, at least in animals. So you do all the experiments ups and downs, from behind, from front, in order to confirm that you have a good drug, a good candidate. And even, as I said, you can show that in hemorrhagic models, in ICH models, the apton also seems to have a beneficial effect by slowing the growth of the hemorrhage. So this is very good news, because potentially here again, it tells you that you have a drug that you can give to patients at the pre-hospital setting without being sure that the patient is having an ischemic or hemorrhagic stroke. And this will help no matter what the patient has, or at least it will not harm those with a hemorrhage. So this is also something that we want to see with your drug, because it will help you in the later phases. And the beautiful thing about this drug also, for example, is that it seems to work also in blocking inflammation in other models. In a big model of myocardial infarction also, and by the similar mechanism, after shows to reduce the myocardial infarction area and the ejection fraction or other parameters that you can measure in the heart. So it looks good from many points of view, but again, we are tired of seeing that when you translate this to humans, it doesn't work. So we try to do our best with the best selection or definition of what would be the clinical development in humans. First, when you do your phase 1 studies where you load an increasing dose of the drug to healthy volunteers. And again, remember, healthy volunteers may behave very different from all the patients with the ischemic stroke, in which they may have a renal impairment or the renal function impairment, the hepatic problems, where the drug might be synthesized in your liver, or the blood-brain barrier is completely different and is leaking. So, but first we need to start with healthy volunteers, increasing doses, check for the half-time life of the drug in humans, which is not going to be necessarily the same as in animals, and then for potential adverse events or severe adverse events that we may see. And the profile of the drug in this case was relatively safe. We did not see any adverse events, at least as compared with those healthy volunteers that received the placebo. And we could determine the plasmatic curves concentrations at single dose with multiple doses, so you can measure what is your half-life, how long it takes to reduce to 50% the concentration after administration, and typically it's within 12 hours. So it tells you that if you give the drug and now, at least more or less during 12 hours, you will be covered by the effect, or the drug will be doing its effect during the first 12 hours after that. Here you can, but then when you are confident that you know enough in healthy volunteers, you jump into patients. And this is a real challenge, because now you don't have the control of the situation. You are not going to be able to perform all the blood draws or the imaging that you want, because those are severe stroke patients. Again, it is not the same doing research as secondary prevention, for example, in which you can control many things. You have time to inform the patients, the families. You can program an MRI 2 days and a half later. You can program blood extractions, and you can program urine samples. This is something impossible to think about, and that can be consistently done in an acute stroke patients, where many things can happen at the time. So you need to define your clinical protocol as similar as standard practice, because otherwise you're going to have too many protocol deviations. In any case, I was saying, ideally, you want to reconsider neuroprotection in this reperfusion area, at least initially in an homogeneous group of patients with a similar ischemic stroke, let's say terminal ICA, M1 and proximal M2 occlusions, in which you're going to give endovascular therapy, and you know that 80–90% of the times, a few hours later, you will have reperfusion. So this was our point of view. Very homogeneous baseline population to avoid noise, candidates for thrombectomy, and you give the actor as soon as possible after you confirm the inclusion and exclusion criteria. And here is the publication. I'm going to go about some critical details that I think that make sense, not only for this trial, but in general for neuroprotection in 2005. So we designed the trial, as I say, but we included some kind of imaging criteria. So I think CTP perfusion studies can have a very important role, at least here, right? We have seen that for selecting patients for thrombectomy in the early time window, it might not be necessary, or it's not necessary, but to identify this population in which you have a very good prognosis with the standard of care, meaning without the drug. You don't want these patients that receiving the standard of care will have a fantastic outcome. As I said, that you want to exclude them from your trial. They're going to dilute the treatment effect of neuroprotection. because there's a ceiling effect. We cannot do better. So we decided those patients with very good profile to exclude them. We also decided, and here I don't know if we were right or wrong, to exclude those that upfront have a very bad potential outcome, because we thought there's going to be also a floor effect. Yes, here you can see that. So you included in the trial only those in which you expect to have a moderate bad prognosis outcome with the standard of care, and in which you have the highest potential to show a difference with the drug. Here you can see what is going to be the final infarct and the impact on the NIH. So yeah, you put them on this line. If you apply a neuroprotection measure, whatever it is, you're going to shift patients, let's say, from 150 to 100 millimeters, right? Now, if you include patients that with the standard of care will most probably have zero infarct volume, and neuroprotectant cannot show any benefit probably, or very little, and then your effect is going to be diluted. On the other hand, if you include those patients with massive strokes, yes, you might reduce a little bit, 10%, 15% the stroke, but the impact of the NIH, the clinical impact, is going to be minimal. So you want those in which you're going to see the most value for your money, right? And for your effect is going to impact the most the NIH, for example. So we decided to treat those that are the sweet spot here in the right? And here's an example, right? If you take all patients and you reduce 50 millimeters the final stroke, on average, you will find a decrease of less than 2 points in the NIH. If you are capable to select only those patients that will not have a final infarct of 0, or will have it less than 70 milliliters, yes, instead of less than 2 points, your average improvement is going to be 3 points. So 50% more impact in the clinical outcomes if you enrich your population and you select it better. So we did many scenarios, and we came out with this scenario, as I said, in which we will select on CT perfusion those who are expected to have a moderate to big final infarct according to their collateral status and their baseline CTP maps. And this way, we had a limited budget, so we could only perform a clinical study with 150 patients, more or less. And we had to find what is the best dose. So we had in the first phase some dose escalation according to placebo. Then we selected two doses to go to the next phase, to the phase 2B, and we compared with placebo. Basically, we were able to keep the drug 3 hours after symptoms onset. The low dose, the high dose, and the placebo you can see here, and which is good. But maybe in the future we need to do that better and to give it earlier, and again, if possible, at the pre-hospital. As you can see, despite the patients on admission have similar infarct course, and at 72 hours on the MRI, you could see a sustained or significant reduction of the final infarct volume on flare with high dose of the drug. The NIH again was similar on admission, but significantly lower when patients received the high dose. And here, finally, at 90 days, you see this impressive shift in the rate of good outcomes in patients that received the high dose of the drug. So we were, this is very, at least we need to be cautious, a small number of patients, but very, very promising. Moreover, you can see that the effect was higher when we were giving the drug in the early time, within less than 3 hours. You can see here the effect is bigger. The final information in the NIH change, if the drug was given after 3 hours, the effect was not so powerful. So it makes also sense that the earlier you give the drug, the more it's going to work, the higher is going to be the effect. And with the fast progression again, or moderate progression, remember we excluded these slow progressors, but the effect was highest among the fast progressors, and that makes sense again. And finally, in those patients who did not achieve a complete recanalization, we could see a higher difference as compared to placebo. If everything goes well and you recanalize very fast the patient, it makes sense that the differences with placebo will be lower. If you leave some areas of the brain with some degree of ischemia, not completely, but you achieve some degree of only some degree of recanalization, the drug in the following hours can still do some effect and show higher differences with the placebo. So at this point, I think there are other molecules that are showing also similar results, promising results at least. I think we learned a lot from failures in the past, from thousands or hundreds of thousands of failures in clinical trials in translation from animals to humans. Now we also have probably better drugs, but we know better about stroke. We do have a powerful ally that is thrombectomy for these patients. So the combination of thrombectomy and neuroprotection hopefully will succeed in positive trials in the next future. And remember, the beauty about this is that if one drug shows an effect, it doesn't mean that a second drug cannot be applied together with the first drug. If they have different mechanisms of actions in different pathways, you can help the patient from different points of view or angles with reperfusion, with anti-inflammation, with anti-apoptotic drugs, and yeah, hopefully we'll have a nice scenario to show the effect of these drugs. So thank you very much for your attention. I hope you enjoyed the talk and see you very soon.
You will not be here to comment, but any questions, comments? Neuroprotection will say life is great if you're alive. Very interesting. I was in a meeting with Mark, and his researcher from Mass General Hospital actually pointed out that the reason all this thousands, like millions and millions of dollars in research, this circadian rhythm of the rat is opposite to ours. We're day animals, they are night animals. And all these studies were done with the infusion of drug, consider the animal as a day animal. And this changed your metabolism completely. So there's tons of evidence to show that why you need to sleep and all that behind circadian rhythm. So we invest a lot using the test animal at the wrong time of the day. So they went back and tested the rats the opposite. Doing the drug during the night, and the results on rats is exactly the results in humans. The medications fail when you flip to the day. Most of the strokes is daytime. It's fascinating that during 20, 30, 40 years, we wasted a lot of money and resource chasing these drugs that were tested in rats during our daytime, but for the rat, their circadian is flipped, so all the metabolism is reversed. So it's very, very interesting that this guy figured that out. We're going to invite him for a talk, but that's pretty intriguing. But I think that this is they're going to a phase 3 trial. That's what Ray Stahl is at the next level. But this is looking pretty good. I hope it'd be great to have this at the back of the truck, eventually paramedics, the medic is skinning him, right, and the stroke is push the drug and help the brain, slow down the growth of the infarct, so I think it's gonna be super nice. So our next talk is Dr. Nima. He needs no introduction. I use this term a lot, the energizer bunny. Dr. Nima is the energizer bunny for stroke intervention, education, and all things stroke related. Dr. Grande, I don't know if he's up yet. He was having a good time on the post conference session. But when we were hiring our first partner for intervention, Dr. Grande was here as a fellow. You've got to interview this guy from he's tired of hearing this story, but I always like to say that because it's all true. They got to interview this guy from Pittsburgh, Dr. Aga. He's golden, and Dr. Grundy was spot on. He was right. We're very lucky as a system, as a community, to have Dr. Amin Nima Aga Ibrahim among us. So take over, Dr. Nima.
All right, thank you, kind. Thank you very much. So, the people who are daytime, apparently, neuroprotection doesn't work. So people who are not here, I'm assuming those are the 9 people there. So maybe it works for them. Thanks for having me. I am really excited about the conference. It's great to see everyone. I do want to say thank you. This conference has been going on now, obviously every year. A lot of work goes into it, and the people behind this do a great job. And I just want to thank everybody. And we're lucky to be in the era where we can actually make a lot of difference for our patients. So thank you guys. So we talk a lot about acute treatment, which obviously is very exciting. Neuroprotection is another frontier which is future, I think, bright. Now, secondary prevention is something that is more practical to day after they pass the ER. And as you know, everybody was here from ER. It's busy, right? Because stroke is very common. I just looked this morning. Guess how many code strokes were this morning? Just code strokes. There were 3. It wasn't that bad, but it's pretty common. But once the patient has a stroke, then what? Then where do we go from there? Stroke management is really divided into prevention versus acute treatment. And the prevention starts with primary care, right? Everybody here, you guys should know your risk factors. Does everybody know the risk factors?
Yeah.
Cholesterol, blood pressure, those are very common. I know, for example, somebody here really knows this risk factor, Dr. Salvador. Myself. Why? Because we talk about this, and I think it's good to know your risk factors and modify them. Because once you modify those, then your risk of stroke or cardiovascular disease goes down. If somebody already has a stroke, that becomes then secondary prevention. So what are the types of stroke? We need to know the types to try to prevent it, right? I don't see any of our fellows here that I can quiz. Oh, the tab is like that. I see you. I'll tell you, what are the types of strokes, skinny strokes? Okay, so cryptogenic, I agree. I didn't hear anything else. Keep going. You're not on the spot at all. I only have 30 minutes. Okay, cryptogenic, what else did you say? Cardioembolic. So is there any criteria that was used to classify these? Anybody knows the criteria that we use pretty common? Nobody? Toast, right? It's learning, basic toast. Anyway, so TOAST was a trial looking for anticoagulation, and they divided the strokes into subtypes. It's not perfect, but it's a very common that is used pretty much going forward. Things were divided into TOAST. I like TOAST, but I also like my own TOAST, or I call it NEMA TOAST. It's a NEMA modified TOAST, and really it's what we do on a day-to-day basis. When you see a stroke, is it a large arterial disease? But I don't stop there because intracranial vessels and extracranial vessels are different. For example, intracranial vessels, unlike extracranial carotid, for example, or coronary, they don't have the external elastic lamina. And intervention inside those vessels are more dangerous. So I divide it into intracranial versus extracranial. Then you have cardioembolic, you have a small vessel, you have the cryptogenic, but we don't stop there, right? Now you have ESIS. I consider PFO part of that, because at the end of the day, did PFO cause a stroke or not? The hypothesis is yes, but we know that for sure. Then we have non-embolic stroke without causes. That's your really cryptogenic. That's actually very common. That doesn't fit any of those that we talked about. Then you have rare cases that more rare and you don't see that often. So, what are the options? When you have patient with a stroke, what are your options for treatment, prevention from happening? It's really divided into medical management, primary, secondary. That's really the main goal. But then you have surgical intervention. Now, surgical intervention for secondary prevention is different than, for example, the thrombectomy, right? Now we're not talking about the emergent patient that comes through the ER. Now we're talking about somebody who is assuming it's stable, but we're trying to prevent that from having another stroke. So you have a lot more to lose, right? So you have to be more careful. Then you have lifestyle modification. And I don't know, this guy is there, the kid's running faster, you see everybody's just around him and a lot of pressure goes on. But it works. And I think we all should do a better job of having a better lifestyle. The blood thinners are very common, right? We talk about blood thinners a lot, and I try to keep this practical, but NOAC is what we use very common. But really, when we talk about anticoagulation for stroke prevention, cardioembolic strokes are the ones that are really being proven to benefit from anticoagulation. So these NOACs, for example, you can see the practicality of it here, that we use pretty often. Eliquis start to grow. Why? Because it's twice a day, but it has less bleeding risk, and it pharmacologically makes sense. But I don't care. You can go to Xarelto, Perdaxo. People don't tolerate Perdaxo a lot. I had a conversation with our under ICU. Yeah, switch them to Perdaxo. But guess what? A month from now, they come to your office and say, you have GI stomach problem. So Eliquis is used AFib, clots in the heart, DVT, whatever. But then when you have intracranial disease or carotid disease, these haven't really been studied. So then what do we have? Antiplatelets. Do you have 1, 2, 3? How many more antiplatelets you want to add to somebody? 3, 4? More the better. No, there's evidence. So if you look at the data, we worked on a point trial which tested aspirin and Plavix versus aspirin within the first 24 hours. Then you have the Inspire trial that came out in 23, showed yes, aspirin Plavix helps within the first 24 hours, but also within the first 72 hours. So I think we're becoming more liberal in giving somebody aspirin Plavix load when they come through the of the stroke. Actually, there's some evidence that if you give Plavix load, it's as good as TNK, sorry, Dr. Sunstein, for mild strokes. So bottom line, I think dual antiplatelets is used common, but obviously you have to be careful. What happens when you start somebody in Plavix and they leave the hospital? Guess who stops it? Either they run out, they stop themselves. But if they don't run out, nobody's comfortable stopping Plavix, I found. You know why? Because they don't know why somebody added Plavix. Like, oh, I'm going to be fair to go restart Plavix. Do you have a stent somewhere? So it's not uncommon you start somebody in Plavix, and 5 years later, the grandma has a subdural hematoma and say, hey, why do you have Plavix? I don't know, my cardiologist said I need Plavix. Forever? So it's good to have a definition of how long you're going to continue that. Usually, I tell my APPs that I work with, let's at least have a plan. It doesn't have to be exact, 3 months, 1 month, whatever, pick a number. But to some people, long term, that would be more rare. But accumulative, so bleeding, right? How about aspirin and Rolenta? Well, there's another trial. Guess what? That showed there's benefit of adding aspirin and Rolenta. How about Rolenta versus Plavix? Well, Chance 2 trial was in 2021, which showed people who, remember, these are Chinese population, people who did not react to Plavix did benefit from Rolenta. So as you know, we check Plavix response, pretty common. And this is pretty interesting. The Chance was published in, man, my eyes are getting bad. What year was that? 2013 was started in the publication. And you can see that the dual antiplatelet prescription went up. All right, you can't just keep peek on the tab. See who else is here. And, okay, I see ROR and some other stuff. Thanks for being here. I am putting 2 pictures here. Can somebody tell me what are the differences between these pictures? Actually, it's very easy, you can say a lot of things. Anybody higher, want to take a guess? I see one of our neuroradiologists here. I don't want you to be too technical, can you just simply tell us what are the differences? Sorry, I couldn't hear you well.
Middle cerebral artery.
Ah, right and left. You have the blockage of the middle cerebral artery. One of them on the right, one on the left, right there. You guys see that? So these are acute strokes, obviously. What are the causes of these blockages? Are there any difference between how these two got blocked? Or could they be the same? Would you approach them differently? The patient, these both came with high NIH. I'm gonna ask Dr. I'm gonna ask Dr. Hannah actually. Dr. Hannah, acute stroke, all I'm asking is your approach is for both of these. I don't want technical, I'm just asking, would you use the same approach or would you use a different approach to treat it as acute stroke thrombectomy?
I would use the same approach. I would go through the groin and try to get the whatever is blocking the vessel.
I think we all do the same thing. It's acute stroke, high NIH, there's a blockage, try to get it open. A little farther down blockage is the ICA terminus. You guys see that? So the dot, by the way, sorry, I show pictures, for example, to people like EMS, and it's like, it's so obvious. So they're like, look, it's obvious too, you have to explain it. And they're absolutely right. We have the groin, you have a catheter right here, right? And then you injecting dye. Dye is dark and goes through the tube. It should not stop. See, it stops right here. Why does it stop? Because there's a blockage. So these are the tubes that then gets blocked. Something's blocking it. So my question is, are there any difference between what caused this problem? If it wasn't, I would have told you. Because once you open up this blockage, if you do, guess what? Now you have to figure out, okay, what are you gonna do to prevent this from happening? So you can put each stroke into the TOS category, hematose if you're interested. That's the important part to prevent the stroke from happening. That's the inpatient work. So here's the first one. This is what I showed you guys right there. This is the lateral view after it was opened up. There's an arrow right here. What do you guys see there? Anybody? I can't really quiz people. What is there's an arrow right there. What I'm showing is these vessels are diseased on this patient. So guess what? This patient got a thrombectomy, it didn't open up, diseased vessel. And there's a stent, which you don't appreciate, it's hard to see, but there's a stent actually at the end that I have to put in to keep this vessel open. So what's the cause of this stroke? You could argue differently. Dr. Savage likes to argue that at the end of the day, you're not gonna know for sure. You're absolutely right. At least I have to go with something.
Not to have an OCT that you know.
I don't have OCT. Oh, yeah, I guess. I'd be a little uncomfortable putting OCT in the green flame vessel though, still.
You will, I know you will.
But I think looking at ACA, I mean, this patient has bad athro everywhere. So I think the cause of this was intrinsic disease. Whereas this patient, as you see, the clot was sitting right there. And it came out in one piece. What's the cause of this stroke? Let's see, one of our hospitalists, I appreciate you coming. Sorry, I don't know if anybody else here. What's the cause of this blood clot? Which is the most common cause of a stroke that we deal with? Acute thrombectomy is a cardiac block, it's Asian. You can see that, the blood vessel is, the heart is, clot is just goes up there. It's dislodged or lodged somewhere. Now, what's the cause of this stroke? Well, yeah, I'll work hard on this, so wait for it. Oh, it was supposed to come from the heart and fly, and anyway, I was trying to make it exciting. All right. That was also cardiac. So when it comes to ICAD, the question is, what do we do? How do we manage intracranial atherosclerosis? This is the one that we don't really have much new exciting stuff. This has used to be maybe exciting, no longer is. People get bored with it. But guess what? It is the most common cause of stroke worldwide. And the global incidence is very high, especially in Asians. And the US is 10%, but it's more common in Asian and Black and Hispanic. And there's asymptomatic ICAD. So what do you do with that? How do you diagnose virtually find if you have ICAD, right? So we have imaging, a lot of imaging. Dr. Hanel brought up OCT. I think OCT is a great future. For the first time, we can actually see the inside of the blood vessel rather than just keep looking and looking, right? How do you measure narrowing in the vessel? Same as what we do for carotid, same NASA criteria. Does it matter how bad the narrowing is? Well, yes, there was a Veritas trial that showed if you have a narrowing blockage, more than 50%, more than 70%, the rate of stroke is higher. So what do we now? We have ICAD, and then we're gonna scratch our head and what do you put? Throw all the blood thinners at them, throw everything you can, and tell them to fix their stroke, diabetes, whatever. At the end of the day, here's the problem. The incidence of stroke is still very high. I don't care who says what about Sampras and all other trial, but look at the stroke recurrence in medical. 5.5% in 30 days, 15% in 1 year, 17% in 2 years. So when we talk about ICAD, I don't like the fact that we say, oh, we have medical management and then go home. No. If you tell me somebody has a 15% chance of stroke in 1 year, that is high, right? What's the risk of a stroke in AFib if you're not anticoagulated in 1 year? Around 10% if you have a high chance of stroke. What's the rate of stroke in carotid disease? So putting things in perspective, we still have a lot of strokes happening recurrent when you talk about ICAD. So then what? But is narrowing really the only thing that matters? So we talk about the degree of stenosis, 50%, 60%. But is that the only thing? I don't know. Let's go back. I think same as MEVO trial. It is really exciting when you actually dig deep into something like, wow, no wonder why some of the trials were negative. Do you really understand what we're doing when we're doing Sampras? I don't know. I was too young. But I still don't know. I think to answer that question is, when you talk about ICAD, how does that cause a stroke? Are they all the same? So I'm showing you a pathology picture. It shows a kind of a round, smooth lumen, right? And this is a stenosis in the blood vessel. If it's too high, degree of stenosis, maybe can cause a stroke due to hemodynamic changes. And then here's a picture of it. What is this? Anybody likes pathology? Well, this is your plaque that is no longer stable. This is a rupture plaque with a thrombus inside and blood clot. This is your large artery disease. This is that big vessel that blocks off. Or a little blood clot from it goes, it still causes a problem. Different way, mechanism for stroke. And then, how about this one? What am I showing here? Anybody? Not actually showing me wrong, I apologize. But you see that little rectangle down here? So this is a blood vessel, and there's an important branch coming out of it. Right, so that's a blood vessel, and there's a branch coming right there. And guess what? If you form a plaque right here, what happens to that branch? So if the plaque is forming right inside here, what happens to that branch? It goes off, and then guess what? The patient has a stroke. So how in the world, I was gonna say a bad word right now. How in the world would you tell me if you put a stent here, or balloon, whatever, you're gonna fix this guy's problem? No, you're gonna make that worse. So why in the heck would you revascularize a perforated reach artery? Makes no sense. Well, retrospect, going back in Sampras, for example, there were perforators that we were fixing. But I think we have to be more smart as what was the mechanism of that ICAD that led to stroke and address the underlying problem. Mid-basal, for example, we have patient with high NIH, with mid-basal stenosis. Why do they have a bad problem? Because they have a pontine stroke right at the area of stenosis. And you tell me, if you open up that blood vessel and that mid-basal, are you going to help that pontine stroke? No, you're going to make that worse. You should not do that. So this is called branch occlusive disease. This is your lacunar infarct due to a larger vessel. All right. So mechanism of stroke in ICAD, I think, is very important, and I'm very hopeful with OCD, with different future studies, with the MR advances that we have. We can hopefully get a better understanding as to what causes stroke and then address the underlying problem. Now, luminal narrowing does matter, obviously. If you look at WASP was one of the older studies that looked at, blood thinners and whatnot, but at least it gave us a good information about if you have an artery that's more than 70% narrowed, the chance of a stroke from that is a lot higher, is what this graph is showing. So Sampras used that, and in Sampras we use 70%. However, as I mentioned earlier, the luminal narrow, the stenosis is important, but it does not account for laterals, does not account for is a flow down, and it does not account for plaque vulnerability. I see our great radiologist here, we talk about vulnerable plaque. And I think it's important to say, okay, is this the one that has a vulnerable plaque? Is it smooth? I would like to know intracranially how better we can assess that, because we're doing that on the carotid now, but intracranially, I'm not sure if we're really getting that information. Because plaque composition, it correlates with stroke as well. And if you look at the data, especially carotid, for example, it does increase risk of stroke if you have vulnerable plaque. And as you know, when you have plaque, you can go outward, you can have positive remodeling, negative remodeling. And Captiva is a study that we're involved with. And I especially like it because it has a cool design. Pointing out the design. Captiva, actually, we're part of. And it's a study where it has 3-arm, double-blinded, you don't know what the patient's getting. They have to have intracranial atherosclerosis, 70% or more, can be anterior or posterior. And they're randomized to ticagrelor, low-dose rivaroxaban, or clopidogrel. We don't know what it is. And they all get aspirin, and they all get intensive risk factor management. So I think it's a great trial. I can't remember how many are involved or enrolled, but it's going to be a little longer before we get the results of that trial. But I'm very hopeful that this is a good beginning to finally understanding what can help. But is that enough? No, I hope I just proved to you that it's not enough. We need to figure out what's causing the stroke to begin with. And Captiva has another part, which is Captiva MRI, which uses advanced MRI, and the hope is we can determine which patients in Captiva, so remember, in Captiva, you are doing best medical management, right? So if in Captiva you're having a stroke, that means you have failed best medical management that we have as of today. So then hopefully we can get those people and look at their imaging and figure out, okay, what was about that even best medical management didn't help? Then what are we going to do with that population? I am hopeful that is a population that we should be targeting because they failed medical management. And if you look at the studies in the past, Sampras are brought up, visit. Really, when it comes to intracranial vascularization, there's no evidence. Not only there's no evidence, if Dr. Nawal was here, I would pick on him because he loves to quote data over and over, and it is exciting that how much he knows. But the question becomes, intracranial revascularization, not only we don't have data, guess what? We have data against it. But there are some unanswered questions. Asymptomatic ICAD, for example. What do you do if somebody, if I have a intracranial atherosclerosis, what do? Do I take an aspirin? Do I take Plavix? I'm sure I would put myself on a statin, but I don't know. I think those are the unanswered questions. But how about anticoagulation? I think that Captiva hopefully will answer that question. And then, did you do 1? Did you do 2? How long? So if you put on somebody on aspirin Plavix, so we're talking about how long for ICAD, how long would you guys continue that aspirin Plavix? Okay, if you're a patient has a stroke, you sit in the clinic, you're going to start the Plavix after 1 month, 2 months, 3 months, 6 months, 5 years. We don't know exactly, however, samples remember in 3 months, point in 90 days. And then we know based on other studies that after 1 or 2 years, there's a high risk of bleeding, so the risk benefit kind of goes. So I think 3 months is a good window, 90 days, that's what I would do in practice. But I have some people that I continue on a longer term. How about endovascular therapy? Thrombectomy, is very effective. It's a powerful treatment for acute stroke. It's a very exciting field. But when it comes to intracranial vessels, it has not been exciting. And like I said, not only there's no data. Look at this. It's a class of recommendation 3 on. So you don't do it unless you absolutely have to. So in conclusion, I'm going to work every time. I don't see any time keeper. Medical treatment is mainstream of ICAD. You have ICAD, guess what? Medical management is the first treatment. That is it. Now, I do want to make sure that you understand we're not talking about an unstable patient. For example, Dr. Chagasani can have a stroke patient in the ICU. You sit him up, that patient having symptoms. I just want to say this. Great. If the patient is unstable, that's a different category for me. This is not talking about our unstable. This is your patient that is on the floor or at home, come to see you and they have ICAD. When the patient is acutely symptomatic or even acute stroke thrombectomy and they're having ICAD, that's a different population. But medical management is the mainstream, and vascular treatment may benefit if they have failed medical management. And also, we do need to do a better job with intracranial revascularization. The stents that we have are not best. There's not much funding that goes into the intracranial work after acute thrombectomy, and I hope that we have a better tools. A little ounce of stent is what I use if I have to, but sub-maximal balloon angioplasty or covered balloon, there are different things that can be used. And then, we use a lot of integralin, kangaroo, Prolenta. I mean, those work, especially for intracranial atherosclerosis. So, for the last 5 minutes, I want to go over a case that I have. It's a very dear case for me. She was a 6-year-old who presented with multiple strokes. I mean, she's had multiple strokes. And I see her and try my best for medical management, right? And she has intracranial disease. She has a history of hypertension, diabetes, and hyperlipidemia. Now, again, presents with more strokes, of course. But one thing that got me was, she's young, right? She's 60. Her life, you talk to her husband, he is not good. Meaning, even though she's had multiple strokes, she's okay. Meaning cognition-wise, everything okay. But guess what? She can't really walk. Why? Because her family and herself, every time she exerts herself, she falls. And it's kind of weird to think about it. But what happens is her legs, but guess what? She's not walking. How do you think she's going to be exercising? She's not. How do you think she's going to be doing? She's not really doing life, obviously. And then she has a syncope, comes to the ER, and they get MRI, right? Why get MRI? But guess what? The MRI showed a stroke. So this is her pictures in September of 2024. And on the bottom panel here, you see the right. On top, you see the left side. So what you see here at the bottom, there's an occlusion. Right where ICA goes into the becoming MC and ACL. And you guys see this little nice things around here? What is called right here? Anybody? It looks like a smoke, maybe? Depends on how much you've been drinking or smoking last night, I guess. Dr. Handel said it, but this is the puff of smoke moya pattern that we're talking about. Yes, she does have moya right here. This is the left side. On the left side, the picture doesn't demonstrate very well, but there is a tight narrowing right where my pointer is. And I do understand the picture doesn't show it as well. But anyway, so she has right occluded, moya, left, pretty bad disease. And look at the ACAs. ACAs don't really feel well. On the right, I'm showing you a delay filling, but you can see that the front, it doesn't get much flow. So what do you want to do with this? I'm going to go back. Actually, could you go back one slide? All right, Dr. Savaggio. It's going to be too technical, but what would you do here?
I mean, as you pointed out, when you want to see where the blood is making its way there, so I would sit down and look at all those images and see how the blood is making it to those areas that are deprived of blood.
I love that because one thing I love about angios, I mean, I love angios, as you know, it's not just a static picture, it's a view of arterial phase, capillary phase, lateral, venous phase, in about 2 minutes, jeez. And then this is the MRI showing a lot of flare on the right. Remember, the right was occluded. So what's going on to the left? Well, she had a stroke on the left, not bad. But high up here, you see this hyper intensity here, called an IV sign, meaning, we know up here the flow is delayed. That's what I'm saying. So medical management is the primary, right? She's had multiple strokes, but has she been optimized medically? So here's when I met her. Of course, we put her on aspirin Plavix and aspirin Brilinta, so you cannot say we're gonna go antiplatelet and go home. So here it is. When she started with us, LDL was 91, not too bad. Triglyceride 247, bad. And look at this. This was her main problem. A1C of 10.7. So, sometimes vascular surgery, for example, they're not going to touch anybody unless they get the diabetes control. Makes sense because they heal poorly, and of course they're going to re-occlude whatever that's done. Bad problem. So what do you want to do? Fix it. Overnight? No. So guess what? We took our time. I did put her on medications, and she actually followed my recommendation. And I'm smiling because, when I tell somebody get your diabetes under control, it usually doesn't happen. So here's now. Look, she did a good job. And the fact that her triglyceride is now 99 and her A1C 7.2, again, is still a little bit higher than 7, but come on, it was 10.7 to 7.2. She's taking care of herself. You agree?
Yes.
She doesn't smoke. Activity-wise, again, she's limited, but her LDL is better than mine. So, now what? I think what Dr. Savage said was, well, let's study a little more, figure out what's happening in the brain. We did that. By the way, I'd just like to show this graph. You can see that her A1C dropped nicely and her cholesterol decreased. So, having said all that, this is what I did. Nervously, I did not do this comfortably. At the bottom, on the top, you can see that this is before, this is after. One thing that was interesting is I did this awake, which I'm not recommending that. But again, I was worried about her brain. I put a wire up here to just a little thin wire to just get stuff there. And by just putting a wire, that closed off that little lumen that was left. And guess what happened to her? She passed out. So she started moving around, and regardless, I put a balloon and I put a stent and I opened it up. Of course, I had a lot of talk with her before all this. Why was I nervous? You see these little perforators coming out? If you block off one of these little branches, I mean, she's gonna have a more big motor deficit. Thankfully, she did not have a more big motor deficit, and on delay run, this is what I love about angio, and this is the thing what Dr. Savage was really due to. This is before revascularization, this is after. So the ACAs were not feeling very well in delay fashion, and they did improve some. I'm not going to argue with you, it's not the most beautiful picture. But I think the collaterals were forming, they were just not enough. And this is her in follow-up, and she's walking, and I think that's what steered me. Yeah, she could have got hurt with this. You have to be careful. We did try medical management, we did take our time. Thankfully, this was not a patient who came with a large stroke. So guess what? She's having a better quality of life. At the end of the day, I think I thank you for your time. If stroke and work doesn't keep you busy, these 3 beautiful, crazy kids do. So thank you very much, and I hope you enjoy the rest of the conference. If you have time for a couple of questions, or sure, a couple of questions. I've been given permission.
You did say that normally you put somebody on anticoagulants about 3 months, but sometimes we do that a little longer. And what will that decision be made of based on the risk factors, or how many they have, or
Good,
the
great,
previous history?
great question, thank you. By the way, nice try.
And pen, do you see?
Well, I meant to pen. No, but with all seriousness, you said that, great question, but you said anticoagulation. I want to be very clear. We have antiplatelets, we have anticoagulant. I do not use anticoagulant for intracranial disease. I use antiplatelet. Now, anticoagulant, think more heart, blood clots, DVT, antiplatelet, intracranial atherosclerosis, high flow. I use dual antiplatelet, 2, for 3 months on average. What happens in 3 months? I see them in clinic, I get a follow-up CTA most often. If like stable, not too bad, they're stable, stop it. If looks bad, they have disease in other places and they may not be as well, I continue for 6 months, really bad. And I always ask them, are you bleeding anywhere? And if they're tolerating it okay and their disease is pretty bad everywhere, I may continue it more than a year. So what do I make that decision on? Are they tolerating it? But I do like to stop it at least 3 months, because if I don't stop it, a lot of people will stop it.
Yeah.
Also, remember, some people have coronary stents, for example, so you have to kind of consider whether there are things they have going on, which requires antiplatelet, dual antiplatelet.
Yeah.
Thanks very much.
I think we're gonna have time to discuss, we have our whole hour for the symposium, we can
Yes.
jump back and discuss, just to be respectful to Dimitri, focus is online, but he's gonna be good talk live via Zoom.
Thank you, guys.
Thank you. So, our next speaker is, Dr. Dimitris Lopez. The bail on us could not be here, after his trip to Istanbul. So we're getting a rain check for next year, Dimitris. So he's gonna give us a very exciting update, on, optic coherence tomography. Thank you.
Hello, everyone. Thank you, Ricardo. I'm so sorry not to be able to be with you guys. Actually, much rather be there than about what my day is going to be here today. But I miss you guys, and I appreciate the opportunity to share with you. Please let me know. Can you hear me well?
Yes.
Yes.
Okay, perfect. So, I mean, Ricardo, I think the biggest news and in terms of innovation and what we've been looking for is the next slide. And I'm going to share this with you because the ability to see in the dark, as we say, like looking to push our boundaries from X-ray based imaging into intravascular imaging using technology that is almost like a histology-like view of the blood vessel wall as well as beyond is incredible. So what I wanted to share with you is the exciting news that myself and Ricardo are actually co-PIs of the first study of neuro-OCT in the United States. So we have this is great news, and looking forward, Ricardo, to work with you on this. I think this is going to be, I mean, we've been really waiting for this to happen, and finally it's happening this year. At this point, obviously the neuro-OCT is not FDA approved, so this is the landmark trial to get through the initial assessment of aneurysms before and after treatment. This is kind of the inclusion-exclusion criteria you can see here on the right side. And we're planning to do 10 sites. So, you know, almost 70 subjects, one arm, and it's going to be really looking at the safety of doing this intravascular imaging acquisition. So I think that this slide summarizes everything that you need to know about, like how fast we're going to get this in our hands, what, you know, is the next step. So I'll say that this is probably the most important part of in terms of innovation and what's coming next. Now, the main thing about for those that don't know where we are today is that almost like 30 years plus in the past that cardiology has started this journey of bringing from ophthalmology a technique that was using this light source to be able to actually have see-through tissue, and this is like a very impressive images on the vascular territory, so you can see that many times on angiography was just not enough to know what's happening on that coronary. So by having these type of imaging and what is really amazing about the technology we're talking about, where you have how far you have to move, we're like 30 years into the development of this, and finally we get something that is small enough and flexible enough to be able to navigate into the intracranial circulation. But look at these images here on the bottom left, how you can actually obtain a pre-treatment image. So that even with the probes that we have today, and it was very difficult to do, the neuroprobe allows you to do actually crossing profile is extremely small, that allows you to do a pre and post imaging on a case of stenosis, which is really very unique. Today, this is in cardiology already class 1, level A for evidence, and this is really here to stay basically, and it did take a long time to get to this point, and I think we may benefit from that on the neuro side. Now, from the standpoint of what it took to become, to have a probe that would be small enough and navigable, it took a lot of technology to do that. But what we have now is the ability to have a less than 15 microns of the resolution to see this. So this is really powerful, and I will share this with you that so far we have already seen what will change in our field. We can evaluate basically the disease state, see what type of plaques we're dealing with, what type of inflammation the arteries potentially, or distinguish, I guess, inflammation from plaques, as well as the ability to have see devices healing in the blood vessel after implant, or any type of perhaps intravascular disease or changes that today we cannot understand, or we have somewhat of like a dark view of it by looking at the angiogram. And for folks that to understand the difference here is that the ability to do image of the lumen vessel allows you to see contours. But when you start looking through the vessel wall, now we're looking at potentially what's really happening with the vessel and why you have a change in the contour of the vessel that you're seeing on the angiogram. Sometimes the MRI vessel wall imaging and the CT scan can give you a hint that this is like something is going on there, but not to this degree of sensitivity of being less than 15 microns. The one thing that we are seeing too is the ability to distinguish between things that are inside of the artery, like a clot, is that what kind of composition the clot has, and all these things. I'll show some examples to you. But one of the main challenges of the neuroanatomy were the tortuosity. So when we use the original OCTs from cardiology and I tried to apply them to neuro, it was very common that we would break the fibers. As we went up in the navigation to the brain, we just could not get the probe to be functional. So that's why we had to develop a system that would be very similar to the microcatheters and wires that we use in neuro to navigate this type of anatomy. And remember, here you're going from soft tissues of the neck, then you have the skull, and then you have spinal fluid. So it's different environment. So not only the tortuosity, but also the environment around the blood vessel dictates the type of stress that the device has to go through. And the quality of the image without having any type of artifacts, as well as the ability to do that very fast, is incredible because we have the circle Willis. So imagine that to obtain this type of image, you have to clear the blood from the segment that you're obtaining the image. So the ability to do that came certainly much better when the technology made the device not only more navigable, but also extremely fast in obtaining the image. So the pullback is within seconds. And that allows us, with the intermediate catheters that we have today, to inject contrast and clear the anatomy while that quick pullback is being done. So this is really important. So the name of the company that actually enabled this to happen is called Sprite Medical. And this is really, I have to say, today they're pretty much alone in this market in terms of the level of technology they have to do this. This is the comparison. You may be familiar with all the lectures you've seen in this year's innovation meeting, that there is a wire that we call Synchro, and it's a 14 wire. And here on top is the size of the probe. So that's one of the goals. That was that, can we have a wire that looks very much, or an imaging probe that looks very much like a wire that we use, so that the familiarity and the transition to use this will be hopefully seamless for us. It will be very straightforward. There is, for the endovascular folks, this is really amazing because you can get about 100 millimeters of imaging in less than 3 seconds. That's really impressive how fast it is and how miniaturized it is. This is how this looks like. So you bring a console like this. This is actually fully interactable with our Angel Suite equipment, so you can have a better type of imaging. There's a pullback that allows this wire to come extremely, let's say, that coordinated way between the injection of the contrast to clear the blood, and there's a pullback then to follow that. So that has to be a coordinated type of position so that we have the best image possible. This is how this looks like. So you have, this is where we are today. We usually place a microcatheter position and then place the probe inside of the microcatheter and then unsheath that probe. So this is a very familiar movement for us. So when you inject, the blue is the contrast, and now you pull back and there's only contrast, no blood. And you see how the intermediate catheter being this high in the anatomy, it allows us to clear the blood from the circle Willis. And in this case, you are seeing the position of flow diverters here across this aneurysm and across a few branches. But it's incredible how you're able to then, with a very, the image you can see on the bottom here, you can see what is the position, how fast it is. So, and one of the challenges here is that once you have this type of image and you obtain like so many pictures of this, you're able to then have a post-processing that analyzes this picture. And actually, what we're working on is the correlation between that and the angiography. So you can have basically locate on the middle cerebral artery, for example, where exactly this blood vessel is. And very amazing is that you are seeing beyond the blood vessel into the brain, into the subarachnoid space. You can see all the structures in the subarachnoid space, and this will actually become more clear to you on perhaps some things that you probably are discussing in this conference also, which is things based like the lymphatics, for example, circulation, or things that you would perhaps not identify on imaging, such as blood in the subarachnoid space in a delayed fashion. All these things could be potentially a game changer for this technology. So we're very excited about this. You can see basically all the structures that we're talking about here, the smaller arteries and the veins in the subarachnoid space. And that brings us to how we got that knowledge and how we proved that concept. So the first few cases, 32 patients were done between Pedro and Victor, so between Buenos Aires and Toronto. And this study very much showed that really it was kind of a combination of different disease states. We had aneurysms, ICAD, stroke present there, dissections, and really all the anatomy that you can imagine was tested. So this was an incredible proof of concept and amazing work done by those teams, allowing us to get where we are today. So I think today, going to the USA trial, we're very comfortable that this is going to be very safe for our patients and provide a significant amount of information. And the disease state is that we can imagine that will be most helpful Definitely ICAD, I think is something we're all looking forward to. We're starting with aneurysms. I think it is an area that also will have a tremendous benefit. And acute stroke is definitely and one that probably will help us in situations that we attempt, time sensitive, the first pass and everything. But if you get in trouble and you cannot open or have some challenges getting to your goal of a TP3, for example, it may be helpful to us to do then at that point OCT acquisition or intravascular imaging to sort it out if it's something you just have the wrong tool maybe, and you may need a stent or maybe an angioplasty or change, from aspiration to a stent retriever and so forth. Now, this is really the cool part here. Look at this OCT image of the Neurosurgery. This is a case that there was an aneurysm that you can appreciate here on the left side. This aneurysm, you normally probably would not consider to treat this, is relatively small in size. But what was very revealing when you put together this image and then analyze what exactly was going on here, at this dome of this aneurysm, the thickness of the artery was about 30 microns only. So it's an extremely thin dome of the aneurysm. And what's amazing about this image here in the center is that you can see the blood vessel, and then you can see actually into the aneurysm wall, which is really speaks about also the range of this probe. So you're looking beyond the blood vessel into the aneurysm cavity, into the aneurysm dome. This is a relatively small aneurysm, but you can go as high as like 12 millimeters or so. So that's pretty good in terms of depending on the probe position. That probe in this case is down here. This is the intravascular probe. Imagine that if you're able to position this closer to the neck, you would see then a range of 12 millimeters from there. Another very exciting case was this is a stroke that had happened. They were able to partially canalize the vessel and are having a hard time to see. This was a few days after the event. They still saw that there was a residual narrowing of the vessel, and the Argentinian team did at this point an intravascular image that revealed that this was not a plaque, this was not a dissection, this was actually a blood clot that was a residual thrombus that was present inside of the artery. And the most amazing part of this is that you can even define what type of thrombus this is, and which is really exciting to see depending on the characteristics of the OCT. And this may be something we'll be discussing more and more maybe next year about how to read the OCT images and what each thing means. Now, this is an example from a Toronto case. After full diversion, there is an angiogram in a VAS CT showing perhaps a good placement of the device. But once the OCT was done, you can see that there is a malposition of the flow diverter with a clot already forming and the stress of the flow diverter. So you can see how the segment in the bottom here that is opposed against the wall has no clot in it, and this segment has blood clots in the stent struts. So this led to the use of GP2B3A inhibitor to improve the activation and improve the manipulation was done to make the flow diverter more opposed against the vessel wall. And I think this is a great example of how things that we cannot see in the angiography perhaps would cause a ischemic event, and now you're adjusting and doing this what you intended to do to begin with, but you just couldn't see on a normal angiography. Now, this is probably one of the cases that I thought was extremely interesting because Victor was doing this case. There was an in-stent stenosis, and the question is, do you treat this or not? I believe this patient was doing okay. It was just an imaging changing, and but significant in-stent stenosis. When you do the OCT, you can see that there is actually not necessarily the stenosis was something that was more benign and smooth, and they were thinking that this could be some kind of presence of a plaque that could embolize or anything that would be concerning. But in this case, it was really more a presence of smooth muscle cells and perhaps something that would be a much more inflammation-like thing that could potentially change or still in dynamic and not something that would be something suggestive of an aggressive type of plaque. And that tailored very much to say that this is going to be a medical management versus an intervention, which saves this patient from undergoing perhaps an angioplasty. At least if you wait it out on antiplatelets, likely that inflammation will go away and the patient will actually improve the lumen. Now, this is another case that's extremely interesting because same token stenosis and with the presence of a ulcer, and that was a very dangerous lipid plaque. You can see the characteristics of the plaque is very different than the fiber plaque that we saw before. This is it looks like a sand on a beach, you know, like that's the appearance you can see here. This is a lipid-rich plaque, and this is something that is extremely dangerous for, you don't want to land your stent in there, so you want to go beyond that area, and you also want to make sure that you cover all that with your stent. So this is really important because it's not only the area of stenosis that has the plaque, but also the plaque goes up beyond that proximally and distally. And this is towards the end, I just want to show this incredible example of a vasospasm. And this is a case of an MCA. When you look at the vessels, all thickened. So if you have any doubts that there's could be a differential between perhaps a dissection or a ICAD, you can also have a really good diagnosis for spasm. And you can see classic view of the vessel here. And this is another incredible case of a delayed presentation of an aneurysm, or in case you have multiple aneurysms, for example, to know which one bled. You can actually see the subarachnoid space. In this case, you can see the blood in the subarachnoid space, which is highly suggestive of that was the aneurysm that ruptured. So I want to summarize this by saying that the way we call the OCT for neuro is an NOCT, and the neuro OCT is incredible high quality imaging that you can actually have now the proof and the proof of concept done in the first 32 patients. Up to 75 acquisitions were already done. So it was incredible not see any adverse events with these cases, and a lot of information was obtained. So I think that this is very, very encouraging as we move into the United States trial now. We also, I think, we're really concerned about the technique. So I think we have refined the technique of how to navigate tortuous anatomy, as well as the amount of contrast that you need to inject. And this is, you're talking about, about 18, less than 20 CTs, to get this done, which is of contrast. This is really an amazing, let's say, I think the cost and the benefit that you get from the amount of contrast you're using is, I think, priceless in this case. So I think this is really important. One thing that we run is understand more now is about the radius, the curvatures you go. If you compare a cardiology probe to a neuro probe, the neuro probe can go much better than this radius, as well as small vessels up to smaller than 2 millimeters. Now, if you'd like to learn more about this, I think the publication we have on Science and Translational Medicine, I think is very helpful. We do have also one in Nature that goes over all where we are today. And I think that Adnan and Tommy Anderson have published also a very nice review about the state of OCT and how they see this. And they were not included on this initial, so it's a very unbiased approach to this. I think that it's really important to understand that and see and learn more about it in the perspective of folks that were not involved on the initial development of this product. And here is QR code with the Sprite website. My email is down below. Please contact me if I can help you understand anything else or provide any resource on this. And Ricardo and team, I really appreciate all the Baptist family for this invitation. It really hurts me not to be there, guys. I really do. I have a bunch of hungry tax nurses around me here waiting for us to start some procedures. So I want to appreciate you guys for the time and thank you so much.
Thank you, Demetrius. Any questions, guys, for Dr. Lopez?
Demetrius, this is Nima. Can you hear me okay? And can you hear us okay? Perfect. You know,
Yeah.
you shouldn't feel too bad. I mean, it's only 70 degrees now and it's gonna be a high of 79. And the sun is out, so.
I appreciate that.
And
I have a feeling.
And we're not having any cases today, so we do miss you. Sorry you're gonna be here. Hopefully next time. Great talk. My question is, and I'm sorry if you mentioned this, putting a wire inside a acute, let's say you have acute stroke, right? Inflammatory process, you're gonna be irritating that vessel a bit. Yesterday, for example, we saw that the lumen can be even changed a little bit, even by putting a microcatheter. So the question I have is there any concern in acute phase of a, for example, ICAT to put a wire there just for diagnostic purposes?
I mean, I think that based on what we've seen in the first experience, it looks like we've done this in a very atraumatic way because the profile of the wire. And but I agree with you. I think that we'll have to have a judgment on like how much you can navigate through a certain anatomy in the basically how stable that would be to do. I think that would be really important. Personally, I think it's anything that I would feel comfortable to do some type of microcatheterization is seeing that the OCT image didn't add anything to it. Obviously, if you feel that even a microcatheterization will be unstable, then I wouldn't do it. But the amount of information that you get could help you the other way around, which is like when you make, as you know, in our field, many times when you make the wrong plan from the beginning, it's much harder to undo that. So having the data that you need to make the right choice is worth it, because I think that when you go into the situation of either not treating not because you didn't understand very much what it was, or picking the wrong tool to treat something. Today I think between angioplasty alone, I'm going to use a self-expanding device and do a bypass and then inject, 2B3A and then just remove the centrifugal afterwards without touching or doing angioplasty stenting. We have options, and especially for this particular topic today in the posterior circulation, for example, an ICAD, it's amazing how you can hurt someone if you go and just put a centrifugal and pull the centrifugal out, and you can, if it was a plaque underlying that lesion. And I think these are things that will make user judgment to make the best decision.
Just add to that, I think it's going to be like everything to do with the diagnostic, like risks versus the benefit. A lot of them trying to accomplish and a lot of them going to do that information, how does that change management? Again, putting a microcatheter in the head is not risk-free, but if the vessels are okay, it's low risk, but everything is, you're adding manipulation.
Demetrius, thanks a lot. So my question is that, those images and all that, it's obviously quite beautiful. There's no doubt it's a beautiful research tool, but I'm not aware of the cardiac literature, but I think a lot of those tools, like in coronary, has been used for what, probably a couple of decades. I didn't recheck that recently, but I know that historically, this was used in less than 1% of procedures. So is there a randomized trial now that's shown in coronary that has changed drastically the management, and what's happening in clinical practices? Are people using that? Because I feel like IVUS and all this, every lab has this, in cardiology, but I feel every time we go get the machine, it seems like there's dust on it, so I'm not sure how much they use those tools.
Yeah, no, it's becoming like, definitely there are a number of trials that have shown that, in different situations that, the outcomes are better using intravascular imaging, and specifically OCT has been a differential compared to IVUS. The other part that, it became, standard where most trials now, if you have a new implant being done, it's actually, for you to be part of the trial, you have to be using OCT. So, they are doing a trial now on biodegradable stents. That's for sure a request from the FDA to use OCT on that. So I think it was a little bit of an issue between having a billing code for that delayed. So it's been 30 years in cardiology now. So the issue here is that I think in neuro we'll have the benefit of having early on the evidence that there's safety, but then quickly CMS approval for a billing code for that. And that I hate to say, but the evidence was there, but many times was an issue of the economics of it, you know, and I think that that was what probably delayed quite a bit the implementation of this. I have to say that also in neuro, the stakes, I don't mean this in a bad way, but the stakes are very high in terms of this information for us may have even a higher impact than it had in coronaries in terms of outcomes. You know, here we're talking about a significant, potentially a significant improvement in our safety of the procedure if we know what you're treating. And and also I don't know, but if you guys discussed this this year, but the long-term use of antiplatelets, it's a problem. You know, we had recently a patient had a cerebellar bleed out of, you know, just from being, you know, on antiplatelets after full diversion in a different location. You know, like those things, like we still face this issue of how long you keep these medications on board. If you can see that this is completely healed, I think it will find, you know, that there is a tremendous justification. Hopefully we'll have the billing codes right away, but even without that, I can see us in the beginning using this, even though the economic may be a little bit of an issue, the pricing of the probes and things like that.
Thank you for the great talk. So from a medical standpoint, sometimes we have patients with recurrent strokes. We get MRI visual imaging, and it's a guessing game. We can't tell if this is vasculitis or severe ICAD. Is there a role for OCT to help us make that diagnosis by looking from the vascular, from the inside, I guess?
Yes, absolutely. I mean, absolutely. I think that is one of the great things we're dealing now with young women, basically proximal carotid artery. For some reason, some of the full diversion work is having some difficulties on that location in that population, and we are really at a loss to try to explain what is happening. Is that some reaction inflammation that happens in the vessel? I think all that will have more clarity. You know, certainly, it's like turning the light on something that we've been truly in the dark for and guessing. You know, like you said. So I think that will be very helpful.
Thank you.
Thank you, Demetrius. Appreciate you donating your time, being with us. An honor to serve as national PI with you. I think we're going to learn a lot. Where to use the tool, where not to use the tool. I think we're going to learn this together, and I'm glad we're starting in a collaborative way. We have a big data pool to analyze these pictures and try to do virtual histology and all these things. I think that's going to be amazing new tool for our neurosurgery.
Regarding that one thing, to Eric's point, I think another topic that we are looking to adding to this is FFR. So in cardiology, that was really what they they have FFR with their OCT. So they have intravascular image and physiological image, which is really, that's what became a standard of care for them.
Great. Thank you, man. Have a good day there.
Take care, guys. Bye-bye. Thank you.
So we are 10 minutes late to the program, so we're going to take the break up to 10:25. And we're gonna come back with a panel discussion, about MIVO intervention led by Dr. Nima with me, Dr. Sobajo, Dr. Chumesani. 10:25, guys. Thank you. So we, our. Yeah. We have 35. No, go ahead. 10, 25, 11, one more than
Hey, great job.
Yeah.
Oh, wow, you made it to the conference. I mean, it's my fault.
You? Good, how are you? Nice talk, thank
Looking
you.
good, looking good.
Likewise.
That's okay.
I know it's not a good ball game.
This stuff.
Like back.
Oh. Is that? Yeah, I did a report, like, Doc, share with you that, man. Doc. Four days. Like 3 times in a year.
But yeah, today was like the stroke day was the case. I believe. Maybe that's because it's what it doesn't want to do.
I'm starting, man.
So just say, you know.
Starting like right. This one, number 2.
To you. Yeah.
My name, but I've got 2 names.
I shared with you guys, my, some of the, in the folder. I work in the job. No. Oh, now it's really like every day.
So now, because it's always Saturday, it's almost 25 minutes from my house. Oh, yeah. It's like,
Yeah, just about, you know, just around the time, exactly.
Water.
An hour before the. So I jump start.
Top that. Yeah. Thing that have. You to use, how long do you have it? Probably. The last time I was there, was my second time. 9 years ago. It was organized. And, you know, Monday we. Very. Yeah. That's why.
Yeah, so I don't know. You said it'll send me.
Yeah, you'll get an email.
Get an email.
And a link to your itinerary and all that kind of stuff. Yeah.
And I guess once you get your point, that's true.
You can still upload it.
There's always something like that. Absolutely. Oh, yeah, more enjoyable with your finger on the pulse. For sure. Yeah, you know.
Yes. Yes. There, yes.
No. Oh, really? So, you know, it's tough. I haven't seen it.
Okay.
Maybe she sometimes talks about the. Yeah, but she was here until like end of the, was, I saw her when after. So, oh, yeah, that's okay. They said they're gonna.
Oh, wait. I think it's. Some of the. I'll put it to. Private.
And it's starting to get over.
Yes. Definitely.
That's what it sounds like. Yeah.
Stay here. Next time.
Because we.
That's how it costs.
Covered in the. Like that, that's what we. Yeah. Well, she does it.
Okay.
Like she updates.
So.
Are you local? You live. Just because they lay down. Oh, and they
Appreciate it. Thank you.
work it out.
I know, yes. I didn't know. I still on the team, aren't they, so. Yes.
Yeah, I think she was one.
Simulations.
I attended one. Oh, yeah. There's one here. Come on, here, residents, I think, but I mean, like, I think it's really the. Make it south of the movie.
That's my party.
The house goes to.
Because they're all.
Yeah.
So.
know, south of a little. Very. You know, it's like forever.
But everything happens. I didn't do about this. Never been. I had a friend, yeah, so there's only one foot. One.
I think so. No, it's
Two.
I had to go find out.
Yeah. Like, you know.
Oh, yes.
And yeah. And I started actually, you share. It's just.
Yeah.
I mean, it's not having fun like that.
Yeah, just there with the
Right. No.
Yeah. Right. Yes. That seems to be the whole range.
Along there. Oh my God, trying to think on. I was like, should I go? And I think that they. The life, I can, yeah, but I'm like, well, let me just go, it's the last day. So, yeah. I don't know if we did, I don't think we can. I looked early yesterday, so I tried to listen on my phone. Oh, so I just couldn't keep up. I'm sorry.
Oh, yeah.
It's just a lot of noise and breaking.
Oh, yeah.
Yeah. Fire, but this weekend's gonna be like.
I'm hoping next year I can get on 3 days.
Yeah.
Wednesday I had to.
Yes.
Yeah, with the residents, I don't have same day.
Oh, and now
Well, they were.
But next year, I would have time, I'll be able to.
We've been chatting about like potentially, like, I know we have 4 days. Sure. But just consolidate or two solid days. You know what I mean? Like action. As opposed to, you know.
I like to stay out here. If I know that they have.
Just to get up early, get the things and all that.
Having worried about the side. It's hard yesterday.
Yeah. Yeah, I was here at 6:30 in the morning, so like I just don't want to. In the afternoon.
Oh, they would get over the same problem all the way over.
That was okay. Yeah, it's like just. Traffic when schools and such. Maya, you see?
No, I was saying.
Yeah.
about cardiovascular, that's the first time.
Yeah. Yeah.
So you have to be on for like.
Oh, the physicians, yeah.
They really lose a lot.
Yeah.
Okay.
And I heard that they're, well, now we have, house. Yeah, yeah, they, I heard it's great, I heard it's really good, it's really hard. I haven't attended. Yeah. It's like, dip my toe back, yes. I know, I'm always like, what, when I'm reading notes. Yeah. So, oh, yeah. I'm like, it's usually when I go. That was still kind of like. Yeah, well, we're always a couple of seconds behind. They always are. Muscle fiber, you know, let's look at. Did you see any? Yeah. It's the size of the nail. This much of my nail. It's very small, like very small. And no, it just gets implanted into the muscle, and then it gets. They put it by the nose. It's a. Probably like a nano. You know what I mean? Like, you know, the newer kind of.
I'll get some low voltage on, so it's stay in there, the battery.
Yeah. Yeah.
But it probably doesn't go into battery very fast.
No,
I remember the first one, I was like taking a history of a patient. They were like pacemaker and I'm like, where? They're like, oh, they have one of them.
they're like, oh. Even though very thankfully they have like. And it. And they put it in, they don't have to, you know, it's like brain control, like on the lid under.
Oh, yeah.
the skin. No more. It just helps. So it doesn't. And I mean, like, it does that, it just helps. Like. Yeah.
Yeah. Hey, I see that. I've been sitting there and like, how are you?
That's nice, especially like those patients are like, the ideal surgical candidates, you know, they're.
Yeah, I mean, like.
No,
And then. You know. There was. Oh, yeah. They. Chinese. They planted.
So it's one side, the use pass.
To these.
Guess what, most of my big already.
And the guy was able to start, like, no way. Yeah. So it's like, okay, look, first,
Because
they first started like this. Maybe it's not.
Yeah.
You don't want to.
Okay.
Yeah, but I
want to like say. But I think that we are
Yeah.
Yeah, no, I think it was, they were two arms and legs, it was like, yeah, I don't know. Yeah. Yeah, sure. Study, like,
Somebody had a.
Yeah.
Not big type of.
Wasn't that fantastic?
You don't know if,
It's just we're not having to put it out for private.
it's gonna really like, work, or did it really work, or like how less. You know what I mean? It was just like, you know.
But there's like nothing. It's like they could be in
I know, right? My cousin.
He told.
Yeah.
Yeah, I don't use it as much, but it's not picking up already.
Then yesterday, it looks like one. We always tell them like. You saw that yesterday? I think that's what I heard.
The Zio pack? Do you like the sticker?
Yeah, it's just.
Yeah.
Which is kind of cool.
Limitation.
It's not. Well, people are using them, but then I guess, like partners, like for researchers, you're saying 30 days is not long enough. Actually, said like, really, like 3 to 6 months.
No, it needs to.
I think it's like 20 days.
Yes. Good to stay, each like 3 months. It could be great.
I don't know.
How long are you using it?
But that would be ideal to like, you know, even if you put like a new one on, you know,
The little paths that you can do, like, you can do. Yeah, it's like, but it is, but it's like, it
I was
does.
gonna ask the question.
The whole, like, self-made,
Yeah, no, but they're older data, but that doesn't mean it's not good data.
But this had, spinal cord stimulator, it does functions, do well with the functions, not for neuro, you know.
She put this talk together for our journal club, and I'm using her slides, just want to acknowledge her. And basically, the question is this: what is Vivo? What do we do with it? Do we leave it alone? Do we need medical management? Do we need intervention? We know we have good devices and good ways to get there. So the question is, should we just open up the Vivos and do thrombectomy acutely? Not do that? Medication? What do we do? Well, the exciting 2025 February IC was not very exciting. We think Vivo, which three randomized trial presented their results in this year. And they use basically a different definition for Vivo. It's highlighted here. You know, the ACA, PCA basically, and M2. These are the ways that people were shaped. So, what were the results? Ready? Exciting, not exciting? It did not show any benefit to medical management. And basically, if you look at all the three trials, rate of good outcome at 90 days, if they were had a thrombectomy versus medical management, we're about the same. A slight increase of bleeding in significant treatment. And then we look at the subgroup analysis again, not much difference in the patient population. So all three trials basically showed no benefit when it comes to Vivo. We actually, prior to the results being announced, we actually had to look at our own data, where here knows, if the patient's disability and there's a cause, I mean, it makes sense to go after it, maybe, but I just showed you that the three randomized trial is negative. So we look back at our own data. What have we? We actually did quite a bit of number of Vivos since 2016. We used to not do those initially as much because we didn't have the devices, but as years pass, technology advanced. So when we looked at our own data, we had 353 Vivos in our center. 94 were secondary. We just wanted to look at the primaries. We identified 259, and you can see that NIH was relatively high, 0.7, which is interesting because when you look at the randomized trial that was just published, NIH median was low. Also, age population for the trials were high. I think that's important as well. For us, I think it's about the same. Look at the mean age of 68. Why do you think that mean age was high for randomized trial, higher than the LVO trial? So what I'm saying is ours was 68.7 median age. For the randomized trial, I can't remember, I think it was like 80, anyway, it was higher age. So why is that? Why do you think a randomized Vivo trial had higher or older population? Is it because older population get more Vivos? Anybody? Huh?
More fried fruit. More healthy.
Okay, but if you think about it, on the LVO trials, the randomized LVO trial, the age was younger. So what I'm asking is, why is it in Vivo we had older population? In LVO trial in 2015, we had younger population. I don't think that's the only trial. Anybody want to? Ideology, okay. That could be certainly an answer. I think that it may be also biased, but I'm not saying that's because I don't know. Maybe if I have a 50-year-old that cannot talk, I will treat that patient differently than an 80-year-old cannot talk. When it comes to this, I'm just saying possible. Regardless, so our data showed that let's see. We did, by the way, look at our CTA report, is Dr. Shambles here. And on Vivo, 9% of cases, the report did not identify an acute get this thrombectomy. Why? Because perfusion showed in green, and therefore we took them to antidote and they had a regardless. I think point here is that our facility, perfusion, we do quite a bit. I think in Vivo it helps with inflammation. Our results are that pretty quickly for time. And we basically found that, there are a few things that are important when it comes to Mevo, and these are more technical, but, the first pass effect and successful organization, you can see the data there. And as we did a good job of opening up the vessel, but clinically, again, not much difference, but it was relatively safe. And when we look at the number of passes, so that's how many times you go in or try to remove the clot, doesn't come out, go again. It actually was after a certain amount, it doesn't help. Bottom line, this is one of those things where you want to get there once at least, see if you can get it out. And then we also found that, so there are two ways to do thrombectomy. You can, we have a great aspiration catheter, those are the tubes that you can navigate, if you have a good base, then you can navigate and, you can get pretty distal with those and just basically connect it to a pump and aspirate. Or you can deploy a stent retriever inside the clot and cool that. And in our data, we found that if you have a stent retriever, you have high risk of hemorrhage. That makes sense because you're cooling a vessel that is more fragile. And then, mortality was also about the same. But the bottom line is that the trials that we had did not show benefit. So the question now is, what do we do? So that's why I'm going to present some cases. But lastly, I want to mention for Mevo, we have different options available. We have thrombectomy still. We're part of an exciting study called Perfuse, and this is getting nanoparticles injected inside a distal vessel with blockage. I'm putting a magnet at the top of the head, and the idea is to generate pathways to these spots and allowing the body natural ways to maybe dissolve the clot when it comes to distal. We also have rays. Dr. Chemisani here loves me talking about rays drug. And he said it's better than TNK after 4.5 hours. I'm kidding. Regardless, I think we have a drug available as part of the study. It's a von Willebrand factor inhibitor. And it is studying to see if giving that drug, is IV, can benefit certain patients up to 24 hours. And it'll be exciting to know the results of that trial when it comes out. And then intraarterial TNK is still an option. I don't want to say we do that often. All right, and then we did a nanoparticle for this patient that I was showing you. So I'm going to skip through these and go through the cases. Any questions?
Nima, can I just make a comment? When we talk about options, I think that's something that we have to discuss as a group. There is evidence out there, and I think one of the differences for the European trial, I think they're looking into that, is extended window for thrombolytics. Right? So I think wake up stroke, extend, whatever extend version of that. We had a case last week, Mohammed, right? That we pushed. Was that how many hours was the patient on?
Was 6 hours from the last one. Patient was at Baptist Oak Leaf, so it was not an option to bring the Baptist downtown and do an MRI, so we had to go with an extended IV protocol. And patient got TNK.
And the patient was, because of the weekend, I think it was Saturday, the research pharmacy was not open for raisers, we could not enroll that. But the patient has a CT perfusion that has no core, it's all penumbra. So I think there is data there, and I think something we have to plug into this, and keep looking at catheter information. We gotta remember that for this distal vessels, thrombolytics, it does work. So I think that as a system and as a field, I think we've gotta balance that. It's too bad that we could not get the file from Mark Ribocho, because Mark talked about changing strategy, and he's already doing that. Instead of putting a stent retriever there and pulling, he's putting the stent retriever and he's infusing TB3A or TNK with the stent retriever, doing the job of opening the vessel so the thrombolytic, the drug can get there. So I think we're gonna see iterations of technique moving a little bit. But I think we need to add to this list there, I think extended window for thrombolytics and other strategies like race, there's like the DNA trial going on in Australia. And again, Back to the Future, AJ will remember Cameron McDougall doing TPA and TB3A together for intraarterial infusion. So I think that would be very interesting. I think that the TB3A makes perfect sense for this patient.
I will add IVT and K, excellent time release, and that was business.
First of all.
So, first of all, thanks for the overview of the Vivo trials. And it was presented this year at the stroke meeting. I was not surprised. The reason being is when we look at the inclusion criteria, these were patients with very low NI strokes here. And by default, they do without any management better in the long term. So when you do 90-day follow-up or a year after rehabilitation, you won't see a difference whether there was a treatment or not in many, many patients. So now we are using a technology that's about 20 years old. I remember the first 10 treatments with the enterprise of Solitaire. So we are using an old technology in a new disease because nevos are not comparable with the large vessel occlusion. So what we do is we are stretching the arteries or we are shortening the arteries and basically shearing off all these little branches that come from the artery and enter the brain tissue. They are super, super tiny. So they had in the series much higher hemorrhagic complications, for example. We were not trained to treat small aneurysms, so we thought it would be the same as if we would be treating large vessels. That's a completely game changer. And I think the third important aspect is that some of these patients had TPA on board. We know that if TPA is on board, if the occlusion would have been proximal, that the clot may have broken in pieces and only the hard component of the clot stays and wanders distally or is flushed distally. Now they say, well, we made sure on CT and MRI that that was not the case. But as a neuroradiologist, I can tell you that you differentiate whether a clot is sitting primarily distally or broke from a proximal occlusion and then was flushed distally. It's impossible to differentiate. It's impossible. So we were challenged with a subset of patient population that was just a different one. I do agree with Ricardo's comment that going back, maybe start thinking of thin film stents or some solution which bridge in the early stage the perfusion until drugs then can be deployed. And I would do that without having drugs on board, because every time you have drugs on board, the risk in smaller vessels of manipulation goes up. It's just more risky to work on somebody who's very, on TPA or TMK.
My thoughts is, I don't think the problem is exceptional perfusion. In our data in Baptist, we had 88% perfusion. In those studies, anywhere between 75 and 90 or 88%. It's just the problem is how to do it safely. And we know from before that we're positive. Anytime you have decolonization, the decolonization itself was great with a better outcome. But when they looked at the overall trials, the outcome was negative until they got to do it safer in the 2015 trial. So I think here we're at just a stage where the technology has to be refined. But I'm not going to speak about technology, obviously, researchers have to.
I think one thing to AJ's point, that this was our result from Vivo, and our primary Vivo NIH baseline median was 11.7. So I'm just saying in our group, we have done more higher. But on the trial that were published, I believe it was 6.
And 50% of these patients were M2, right? If I remember correctly. So that's another thing that I think today for me, if I see an M2 at an age of 4, I may pause, but if I see an M2 at an age of 11, I think that for me, that's an LVO type of picture. And the patient has a lot to lose if don't reopen a vessel. But if the patient has numbness or a low NIH, I think we gotta be more careful on the patient selection. I think that for me is a common theme on the people trial that NIH was low at 3.0.
I think one thing I'm gonna ask, since we're having a question in a different way, and Dr. Walker, that's for you. When it comes to Mevo, when you have a high NIH, sometimes I question, how do you know it's not a shower and blood? Meaning, let's say you're going after an M3 with a higher NIH. I guess the question I have is, could you say the NIH disability is only caused by that M3? Or could it be that, this patient maybe have shallow emboli, which then obviously thrombectomy would be probably not good. Right, so I guess how do you differentiate that when it comes to MEVO? Like in one occlusion, I think is different. But when it comes to MEVO, different vascular territory, and NIH becomes a little bit not as strict.
The question. Yeah, that's a good question. The question that came up at the stroke meeting, that the people were very sure that based on the pattern of where the clot was sitting, rather than having multiple branches occluded, that it was a singular event of a distal occlusion. In other words, it was not like an M1 occlusion starting point, and then there was a breakdown of the clot due to TPA, and then you would see multiple branches. So they made sure, but it's not 100%. So in the practice, and that's an important question for you, because if I would see a patient with an NIH of 11 today at Baptist, at your place, I would say you have to offer them a treatment despite the clinical result. Because if it is a very eloquent area, would anybody say to a 55-year-old patient or 60-year-old patient, I'm withdrawing, endovascular treatment because of the trial? I don't think I could justify that. That would be difficult. So now, MRI-wise, it's important to do, not MRI, CT perfusion. I would do all this imaging study to define the core area that's at risk. And those things I would do. I would select a patient based on the imaging. And I think that perfusion imaging can help you define whether it is a singular event or there may be multiple areas that came from a shower of emboli, for example.
If I could add a few things there, so, we need to keep in mind that those study had, except one of them has not shown harm. So they haven't shown benefit, but they haven't shown harm. So I think it's important in the specific decision making. And the other thing is, I do think, as Dr. Walker mentioned, it's a different disease, but it's also mean that, some of those distal branches, like, we all have seen an M1 that the patient does better than when he progresses and become an M2. Why? Because maybe they cut off some collaterals they had by the clot migrating more distally. So some of them, even if it's a distal vessel, maybe the time to completed stroke is shorter than a more proximal disease. So
I think to that point, it goes to perfusion. When looking at the core, it does make sense to have larger mismatch. We're going to go after this. So 85-year-old, older patient comes with left side of weakness, right gaze, and NIH is 8. Disabling or not disabling? Over there. Disabling or not disabling? Everybody? Gaze preference, probably neglecting, and weakness is different. So I would say it's disabling. This is a run of an angio. And can somebody tell me where these MEVO things are we're talking about? Can you pause this video like a, can you, I don't know, start play, stop, go forward one more, stop, perfect. Anybody see the blockage? For a second time, I'm gonna go. So you see that perfusion mismatch right there, that wedge? So again, rejecting a dye inside a tube, everything should light up and there's an area that's nothing light up. Then if you go retrospect, you kind of see there's a smaller blockage. This was an N3. What are you gonna do? For the panel. For Walkload. First of all, it's not an easy case. It's a. I was gonna put an easy case, wasn't I agree, but the reason is straightforward. This patient has the carotid is not a problem. Looks like fairly good-looking internal carotid, but then you have a sudden drop in the caliber of the distal MCA branches. This is a fairly fragile-looking vasculature for me. It's an eloquent area. This person may end up with a stroke. This is the motor area that's affected. I don't see on these images a single vessel, so I would first work that out. The projection where I could approach that. And then I would really consider this patient for IA, TPO. Because the vessels look for me scary, really. It's a patient with that or. Thank you. To be fair, I did not show good images of the there you go. On the right. Left of the screen. Now we see now you see the vessel. It's like. What is the size of the vessel? So did you want me like stop during angio and go in a control room and actually measure it? Yeah, well, I would consider aspiration. No, I'm asking it that way because I think that's a great question, because at the time when I was doing this, I had no idea what the size is. Which goes to the point as to, do we know exactly what device we're using? No, because we're pulling it out of nowhere. And you're absolutely right, I don't know the size. At the time, I did not know the size of this. I would have done that because then the selection of aspiration catheters, not that you jam it and dissect the vessel. That could happen, so I see already on the next image that very bold. Yeah. So, yeah, this is a, I think I'm not gonna use the name for what camera, it doesn't matter. But this is aspiration catheter, you can see the wire there, and the aspiration catheter actually went there very nicely. I did not have to push much, and I think my base catheter was actually kind of low. So we had a support here, and then that was a smooth catheter that just went right through the pot and aspirated, and here it's not very clear, but the aspiration catheter is pretty far out there, right where the pot is. The things of Vector 4-6 and opened up pretty nicely. Just finishing that.
Just for the record, the fact is the creation of Dr. Walker.
Really?
He's happy about that.
I really like that guy. Thank you.
So you're missing the post-op CT or MRI though?
The patient did well. What was interesting about this patient, she had left side weakness and she was able to walk in a couple of days. Did you use any lytics for the mind? I have not done any intraarterial lytic. I don't remember if this patient got IV.
But for the sake of discussion, I mean, that's exactly the thing, like, the images are obviously are nice, but, you know, have you prevented a stroke and all that? I mean, we cannot know based on not having the images post-procedure. And that's the other thing as well, I think in the decision-making, like gaze deviation, no patient will follow up at 3 months with gaze deviation. So parietal deficit and follow-up usually will recover quite well. So those are kind of the little thing when we think about those things that it's hard because as the study came about, I mean, you know, not all the points on the NIH are created equal, so.
I agree, although when I say gaze preference, you know, obviously I did not present that exact exam. To me, neglect would be a big problem. No, I disagree. The neglect people do not do well. As you said, gaze, yes, but when you're neglecting, you're not going to stay in rehab as much. I mean, there are a lot of things that goes with that. But that also suggests a large part of the brain that's at risk. But this patient had some neglect as well. What I don't like NIH is, you're right, NIH was built for left MCL. And it's very heavy pointed for left MCL. And one thing I was going to mention about the exam, we should not be, maybe we're using the wrong thing for our people. Maybe we should be using NIH, same as MRS. Anyway, for the sake of time, should discuss or more cases? I'm going to pick on our neuroradiologist, but I don't think it's fair because I'm only showing a couple of views. This patient came in with 60-year-old, a little younger, left side of weakness, extinction, form of neglect, as you know, low NIH 4. And now I'm thinking, what would I do now? I don't know. Anyway, so presented aspect of 10 and the night before, so we couldn't give it a lytic. Where's the occlusion? Again, it's not fair because I'm only showing a couple pictures. Anyway, so the point of this was this patient presented low NIH and we couldn't find any, we didn't know there was any occlusion. So the patient was transferred and then I'm rounding and this perfusion shows up, and based on this perfusion, we kind of start suspecting something. And the question is, did this patient have an occlusion? When we go retrospect, we could actually find that there was an occlusion that CTA did not pick, which was right there, as we see. it's hard to see the initial runs, but in delay runs, right there. So I guess to Dr. Savage's comments. Dr. Savage, what would you do?
Sorry, when you.
Last night, woke up with left side weakness, extinction, and IHO4.
And when you say weakness, you mean like a drift or a real
Yeah,
weakness?
I guess I give one for extinction, so probably a little more than a drift. I'm not gonna make things up because I don't remember.
It seemed that this patient is worsening, so I would bring to the angio. See what we get.
You mean you do thrombectomy?
Yeah, I'll do the images and take it from there and see.
Well, yeah, the images did not show any core. And then here's the vessel occlusion right there.
This is the one that I would call you and say, why you're not giving this patient TNK extended window chest, no core. There's a clinical trial showing the patient benefit from extended window TNK IV for this. Again, I'm just bringing this up there because I think as a group, we have to bring this in perspective because we have 3 trials, one showing that we hurt patient and age is 4. So this patient is very well represented on the 3 trials. Again, I know this was treated before the trial, so, but again, we're using that for sake of discussion.
The last one was 10 p.m. So extended IA would not be an option because of only within 9 hours. So the only option would be do an MRI for
Wake up stroke.
But let's say she's getting a little bit worse for Savage's point. Do an MRI and to prove this point or do.
Aspect was 10 though. I mean, I agree with what you're saying, I'm not disagreeing, but all the information is last night, woke up, but aspect is 10 at 11:45 a.m.
But the same thing is true, like, is aspect a good tool in distal? I mean, if you have an M3, the worst aspect you're probably gonna be able to get is lose a couple of points at most. So same thing, I don't think it's necessarily a tool that is super helpful for distal occlusion.
Yeah, but for extend window was CTP, CT, and then we have wake up stroke that was MRI. So there are 2 trials there for IV medication that I think we need to incorporate in the discussion. I think this patient will be again a quick DWI MRI, 5 minutes on the magnet. They can close the time to get there.
And I've done this before, and I had 2 neuroradiologists. One saying the stroke is reversible, with Dr. Shimon, because he put the report, but when I called someone else to look at the MRI, said, oh, the stroke is not reversible. Sometimes it's not easy if you see some flare, is there positive or not?
No.
Yes,
So all that I'm saying is, I think we have to pause in the face of these results. And again, for me, it's always, I don't want to hurt this person. I think TPA is safer than my catheter intervention and distal vessel in an NIA4. If that's not an option, the patient's worsening, all these things are taken into consideration. And again, I'm sure you took the clock out and you can show the next picture.
Well, no, let's for sake of this discussion, because we're gonna face this, right? I mean, I'm not standing here, I'm thinking right now, what would I do, to be honest? I think we should, have this some sort of plan. This patient, in my opinion, is disabled, even though NIH is 4, is the right hemisphere, right? So if it was left hemisphere, NIH probably would be 8 or 9, 10. So what would I do now? I think, I don't know, I think,
But this is where my criticism of the prior procedure is that obviously what the MRI looks like after a procedure, but we know that distal vessel occlusion, the patient are looking, again, it's still disabling, but we know they're looking better. So it, happens frequently that you intervene, the patient and NIH won't improve right away, and a day or 2 later, they look much better. And you look at the MRI and there's already a stroke complete in those areas. So that's what my criticism of prior procedure. I mean, I don't know how much parenchyma you saved. Hopefully you did save some, but it is possible that we'll have the same story, the procedure before you show without intervention. And that's what those trials have shown, that we may not be helping as much as we thought because, some of them don't look as bad as we thought they would. So,
my thought here, Eric, is the NIH, right? We're talking, this is an age 4, the other one is an age of 8. So I'm not, again, today, and I think as a group, we need to discuss that and come with protocols. Okay, we're gonna try to push TNK on this group of patients, the extended window, or on this group, we're gonna go there. Instead of, if you cannot aspirate, what about IA TNK? So I think it would be very nice to have a protocol that we can follow as a group, and then, in a year, based on the number of patients that we treated, we'll have a population to show, okay, revised strategy for vivo intervention post ISC 2025. That's what we did, because I think we need this new information, modify our strategy to see if we can help this patient.
Because I think the problem there, as George mentioned, I think it's a good thing we would have a protocol, because I would challenge any of us that we're doing aspiration twice. Most of us will probably say, I'll just stand in one pass with a stent retriever. So I think if we put a firm protocol, and we know that probably by using stent retriever increase the risk of hemorrhage, but I think most of us would, if we committed to open the vessel, at one point, we'll just say, versus if we say we have a clear protocol and we say, this is what all we're gonna do, and we stick to it, so.
Nanoparticles, another option that we have available, so let's not forget about that.
Yeah, may I make a brief comment?
Please.
I think listening to all the four of you who most likely work together on these stroke patients, and you have a huge patient population. What I would suggest is, because you know your outcomes, you have a strong database, why don't you use deep learning algorithms, and there are a lot of them available, to basically improve the sensitivity towards outcome at 90 days, and see what the tools and devices you have used in the past, and the risk profile. And I think there is a threshold, a point where NIH, it will be NIH, I'm sure it will be the age, it will be the modality used, the time, all that. But I would let the machine algorithm for you, or deep learning, for you to figure out this or that patient specific personalized management. And you can do that because you have over the past year so many data. And that would be very helpful to you. You put somebody, student nowadays, they master it better than us. And I think you have a unique opportunity because you are offering all different modalities. It's just now which one to select when in these disciplines.
We did look at, I agree with you, and I think that's a great idea. We did go, in our data found, like I mentioned, stent retriever was associated with higher rate of symptomatic hemorrhage. Even though we did not show outcome difference. And also one other point to the using just the randomized trial, the data we have, I am not disagreeing, but it was a study of the stent retriever space. So I think you have to be careful what we're saying about that. We also found more than 2 passes, you can actually have again more hemorrhage. So I think technique can be different. It's a question that we have, and I think we should discuss in different forms. Okay, so we have raised, we have nanoparticle, extended TNK, and obviously still thrombectomy. We have to discuss how do we stratify and how do we prioritize.
Or Nima, for that particular patient, asymptomatic load would be as good as TPA.
And I before, based on data, yeah.
So,
But yeah.
that's another option.
A lot of work ahead.
All right, sounds good. I think we're out of time. So here what we do, I don't know. We just kind of let it go. No. But to Eric's point, I don't know. This is a big chunk of brain for me. I mean, I don't have data to say anything other than saying I'm looking at that green, a big chunk of brain. And yes, Eric, here's your brain. Thank you guys.
It is my distinct honor to introduce our frequent flyer member of the Innovations Club, Professor AJ Kumar Wakalu. Thank you for making time to come and join us. He's going to show us updates on his newest endeavor, focal biomodulation. Thank you again, AJ.
First of all, thank you, Ricardo. I think I've been here for more than 10 times. I recall, used to be in front of it and then last time. I want to thank Ricardo,
And this whole team for the kind invitation and putting this very important meeting on this. And Randy, thank you very much, and Chris as well. Has been a pleasure working with you guys. I have conflict in the presentation, significant conflict, because I can tell you, I'm dropping the trousers and removing my shirt. It's really that bad. Because I am a CEO and medical officer of the company that is developing innovative technology. We believe in that. And I was yesterday at a MedTech Innovator meeting, and the technology got a very high rating of the judges. I think we are about to change the neurovascular field with this technology, and I want to share a little bit what we have done so far. So please stop me if something is not clear, because this group is small enough that we can have a dialogue. So you have heard yesterday probably a lot about brain aneurysms, and probably it's all way too much, but we started treating brain aneurysms in Stone Age. It was simpler, but then surgery came in. And then in the early 90s, coiling, you have heard of decades on that over the past decades, where basically the bread and butter endovascular, minimally invasive treatment of brain aneurysms. And then they were replaced by flow diverters in many circumstances and flow disruptors in minimally invasive. And now, we treat these aneurysms through the radial axis, through the carotid axis, or through the femoral axis. So personally, I got last year over 3 coronary stent because I got a heart attack. And I have to say, if I wouldn't be at home, the guys were there in 2 minutes. My wife called them, and I was in the cab within 3 minutes. And the doctor asked, "Do you want the chest to be open, or should we do it here?" I said, "What would you do?" He said, "Well, I would do the standing, but hey, it's your choice." I said, "No, my choice is clear. I want this stent." And within an hour, they placed 3 stents in my heart. It was painful, not too bad, but painful. And I thought, if they would have opened my chest, I would be lying there probably for weeks, and the recovery is bad. So the evolution of this, it was a drug-eluting stent. And 2 months later, I'm on the treadmill, play tennis, and a heart rate of 160 back, and I feel very good, better than before. So there were some warning signs, but as doctors, you're at that first stage. So now the question is, in aneurysm coming back, where is this field going? So far, we had implantable devices, and we do believe that we have, as Prometheus, based on a lot of basic research, done the first step in the direction of in situ regenerative medicine. And I want to take you on this small journey from basic research a little bit. Some of you may have heard that, to our recent patient that we have treated. Now, what is the number of aneurysms that are treated? In the United States, we treat about 100,000 aneurysms annually. And worldwide, as you know, the prevalence of aneurysm is 3 to 5%. Now, the expenses we have on aneurysm treatment is about $2 billion in US alone. But when you look at the management of these aneurysms, so ICU care, then you talk about retreatment, angiography, on and on. In the US, we spend about $5 billion. And of course, that translates in a huge number for Europe, Japan, and China. As you recall, surgical clipping is still used in a certain circumstance. We are moving away from that. It's basically deployed in 10% of our patients, mostly for middle cerebral artery aneurysm and some other rare aneurysm. Otherwise, the whole field has moved towards the endovascular management. There are several tools that we have in our coffers for the management. Oils, like I mentioned, are still used. They make about 30 to 40%. And then there are other devices that are placed in the aneurysm inside what we call the pouch of the aneurysm. They are like mesh devices, and the idea is that tissue grows over them. Web is one of them device, and I know Ricardo was one of the leaders in the enrollment for the Web trial. Then more recently, the Contour trial, which is a similar device, like a mesh device, that is being placed in the aneurysm. And
The device that revolutionized basically management of subgroup of aneurysmal flow diverters, because flow diverters, the occlusion rates were somewhere 60-70% at 1 year. And as we go forward, second, third year, the aneurysms keep on progressing occluding. The other devices, however, in large studies showed that they sufficiently treat the aneurysm only in 50% of the cases. Some do a little bit better, like the contour is probably somewhere around 50-60%, the web is around 52%, on and on. But the major problems remains in all these implantable devices, and that is that they are inert. In other words, tissue grows over it, but often they deform over time, and that leads to regrowth and retreatment in 20% of our patients. And these patients are monitored on a regular basis. So they are not, I would say, cured, they are treated, and that's the key difference. When we treat a cancer, we want to be cured. We don't want to be treated only, because then you have follow-up. And the same thing happens to our patients most of the time, with the exception of some cases that are treated with fluid. Why is it so? The reason is very, very straightforward. We have what we call hydrodynamic forces. So with each pulse cycle, energy from heart is translated to these mechanical devices that are placed within the aneurysm sac. So we want basically to get a clot and scarring of the aneurysm before the implant tires out. And tiring out of the implant is it fractures, is displaces, or compresses. It is just that an implant that is made by putting energy itself falls back on the low energy scale and then loses its tertiary form and shape. And we see that it coils very well. Now, when we place the flow diverter, this is a recent paper. What is it, what these flow diverters or any implantable devices trigger? They trigger a very complex reparative function, and that's very important to understand. And the reparative functions come from 3 different parts. One part is, we call them genital cells, cells that circulate in the vessel wall, that circulate in the arteries, about 10% endothelial remnant, or genital cells that basically attach to the implant and start differentiating and populating. So basically covering the whole device. Then there's a very complex signaling mechanism that's triggered at the boundaries between the device and the endothelium. You have to remember that the skin and the endothelium are one of the largest, or not if the largest organ of sensing. So when you touch somebody, it's a sense the body reacts to it. In the endothelium, the same thing. When you scratch the endothelium or get it damaged, there's a signaling process happening that creates like a immune response and reparative response that goes back to the bone marrow. That's the second path. And the third path is they are dormant cells that are called hypoxemic niches. So dormant cells that are residing in the vessel wall of the arteries, and they are there to be woken up. So when there's an injury in the vessel, you get a dissection, you get a scratch or whatever, those cells start differentiating and migrating to the area of damage and populating. When we are young, like in pediatric population, those damages are healed very fast. You see that in your kids, you go home, they scratch, fell the staircase, how fast it heals. And when you're older, it takes days, if it at all heals. Why is it so? Because more recent study shows that these dormant cells, their population decreases with age, but their reactivity also slows down. In other words, their capability of differentiating to reparative cells decreases over time. And all our study with flow diverters, when we do subgroup analysis like this one, shows you that in the older population here in red, as compared to the younger population, so younger than 65, the older population doesn't catch up and doesn't heal as good as the younger population here, 65. So I think 65 is a retirement age for our system as well. So there must be a meaning that Bismarck introduced that 200 years ago. Now, it's not only with one device. This is a pipeline device, a nice study here presented that shows you when we get older, so above 61 to 70, suddenly there's a drop in complete aneurysmal occlusion. So it has to do with the age that our capability of healing stops. It's not only the devices, it's just our genetic imprint
that drives this healing mechanism. So what we did as Prometheus, we did extensive research starting in 2004 in trying to understand how can we use certain wavelengths of laser. It's called photobiomodulation or low-level laser technology to stimulate cells. At that time, the field was just emerging, understanding what it means to tickle these cells in the Western wall. And we focused on brain energy for many reasons. First of all, Barry and I were working on this project. Somebody, the third person, knew a lot about fluid diversion. We had worked on fluid diversion for almost 30 years, and we knew where the problem was. The second thing is we ran into a guy, a scientist, Watson, who was creating photothrombosis at that time. He was creating white clots, and Barry thought, well, maybe we could use this technology for brain aneurysm. Unfortunately, it didn't work that way, but we found something, and that was more fascinating. So in tumor therapy, you know laser. Laser in tumor is used at a different wavelengths for ablation to create an injury, to basically remove the tumor by burning it. So we know that well, and recently there have been trials going on also in the vasculature. There is a company called Spectranetics that uses laser to burn and open up atherosclerotic disease or occluded vessels in the leg. But that's a different wavelength, different energy setting. And it's called type 1 photochemical reaction. We are not working in that domain. Prometheus and the laser we use is completely different action. It's called photochemical type 2 reaction, where there is a very short-lived, highly reactive oxygen signal produced. And that triggers a complete complex cascade of respiratory functions. Some of you may have used fine needling for wrinkle. I do that. That's see how good it goes. So the thing is that recently I was told in the fine needling they add laser. And the reason what they have they're doing that, they found out from diabetes, ulcer, food, from birthmarks that certain laser wavelengths do repair of the collagen disease. And that's why when we go to fine needling, you will see some light, they cover your eyes so your eyes don't get damaged by the laser. That is photochemical reaction to reparative function or birthmark treated ulcers. When you go to a dentist, he has a small laser, and he said, oh, your gums look bad, please give me $500, I can fix it. So, and it really works. I've seen that, the gum problems, the ulcer, it works very well. So we are working at different wavelengths than the dentist, but we are not burning tissue, and they are not burning tissue. It's completely different. Now, I will skip that. That shows the details of all the work Michael Hamlin did at MIT way back in the 70s and 80s that showed that laser light, the photons of laser light, certain wavelengths, induce an electron transfer in an enzyme that's called cytochrome C oxidase. And by that electron transfer mechanism, what happens is there's an upregulation of ATP within the cell, within the mitochondria, which leads, we think, to fibroblasts and myofibroblasts and endothelial upregulation. How would we put it in a simple term? When you take a plant sitting in the basement, it has white leaves. The day you take the plant to the sun, it produces chlorophyll, the green what you see, what the kids say to eat, including myself, who wants chlorophyll to eat spinach, lettuce, all that good stuff. Now, how is chlorophyll produced? It's the same mechanism. UVA light is absorbed. Light has two properties, wavelength and photon. So what the cell complex does it absorbs the light, and through an electron transfer, it produces the green color, which is very important for photosynthesis in the plants. So it's a very similar mechanism. Now, Hamlin also described that photobiomodulating laser light therapy has a direct impact on the genetics and angiogenesis. So that's a different path. So strictly speaking, we really don't know how it works, but it works. So our group under Tim, who is here today, Tim McSweeney, worked with us over the last 4 years. How do we get the laser light through the vasculature to the area where we want to do the repetitive function of the brain. And that was not an easy task for many reasons. First of all, to bring laser light through very tortuous vessels with microfiber, there's a risk that the fibers will fracture. So that was one engineering problem. The other problem is if you shoot the laser light against the wall of the aneurysm, you burn the aneurysm because the heat that's generated is very, very hard. I tried it, really, it takes probably 2-3 minutes, but you burn your fingers. So that means at the tip of the laser light, they had to add a light bulb. Important thing. Then you wanted to stay from the aneurysm and they created a centering piece. And then you have outside a laser, that's an ISO certified laser dot. This is still non-commercial version. So you have two components. You have this disposable component of the fiber, and you have the reusable component, which is the laser power source. So this is the unit for the treatment. Now, how do we make sure that we optimize the deliverability through existing commercially used catheters? So all the catheters Ricardo and his team or Eric use it to fix the aneurysms when they put the coils. Those catheters were used for all our procedures. So we started designing the fiber in a fashion that it fits with the smaller catheters. Then we started doing the animal study as required by the FDA. And there's a rabbit, we call it elastase aneurysm model here. You see the small aneurysm. We shine the light here, laser light through the small catheter. And you see at 10 days, the aneurysm is gone, the artery is open, and the side branches here are open. Now you will say, so what a big deal. But normally this process would take at least 30 days. So what we have done is we have accelerated the healing from 30 days down in the rabbit to 10 days. Now these are rabbits, a healthy animal. Then when we do cross-section imaging through the aneurysm, as shown here, we found something fantastic. And that was at 3 days out, in the samples that were treated with laser light, we saw amorphous clot and early endothelial, so tissue covering the neck of the aneurysm, but also the device itself. So how could the light penetrate, which was sitting in the aneurysm, all the way to the devices? It's not the light, it's a signaling process like Hamlin described that triggers a healing response, and it travels over the entire implant. And that is a very, very important observation. It's a signaling process that makes that possible. And at 10 days, when we harvested these aneurysms, you saw in the samples that were treated with light, there was scarring already visible, and again, an endothelialization of the implant as compared to the non-treated sample, where there was still some clot and some fragment of the endothelium visible. Now, with NIH grants, we had 2 R01 grants that went into the research. We started digging deeper. Which cells are in charge to make this possible? And that was a very critical question. So we looked at batteries of antigens, and there are 2 suspects here for the repair. One is called alpha smooth muscle cell actin antigen, and the other is called CD31 plus antigen, that's for platelets. So when you see on the left side the untreated samples, and you put that under immune fluorescence to a certain wavelength, you see almost no red cells on the left side that are positive for CD31 or for alpha smooth muscle cell actin. When you go to the sample that was treated with laser, the photobiomodulation, we see within the clot that had formed, as well as in the paired vessel and the aneurysm, abundance of CD31 positive cells here, as well as smooth muscle cell actin. Now, what do these cells do? Smooth muscle cell actin cells are fibroblasts and myofibroblasts. They're important for collagen deposit and for smooth muscle cell development. So we are back to what the plastic surgeon do with your see, I don't have them. So, and then the 31 positive is for endothelial cells. So the cells that basically cover the implant. Now, we went then further and we said, okay, let us do a bigger sample size and compare, at 1 week, aneurysms that were treated without light, and these are studies with Monica Killer in Salzburg, which is a GLP lab that's required by the FDA. And what we found out that in the sham group, the group that was not treated, at 1 week, there was almost bare fluid visible with some fragments, we call them early endothelial cells and biofluids. You heard it, the person from Stanford that got Nobel Prize for glycocalyx, for biofluid, and they are seeing that this is lining the endothelium. And here the surgeons know that when they go with a wire up, the first time it sails, the second time it gets rougher and rougher, and that's a fluid, a very thin membrane or fluid that's covering the endothelial cells. And they're working on that because that's a barrier in brain, the blood-brain barrier. That's a part of, we have to make that for our devices in future. This is a wavelength 3 used in this aneurysm, and you see again endothelialization and amorphous clot with some transformation at 1 day to start. Then what we did is we compared distal and crossing further down the arteries and further up, and did some sections, and we saw if we didn't use any lights, you see that there's some early cells maybe at 1 week, and here, this was wavelength 3, you see multi-layer endothelial cells. And when we compare one wavelength with the other, there was a big difference. So why do we do these studies? We want to narrow down the wavelengths. We want to make sure that we have the right energy. Now, the FDA asked us, if you get so many endothelial cell layers, is there risk of instant stenosis? Do you see that the artery narrows down because there's overshooting response? In the rabbits, we have not seen that, nor in the 10 patients that we have treated so far. But that's a concern. The second question that is of concern, can the laser go through the vessel wall and hurt cranial nerves? When you're working on an aneurysm that's next to the eye, and you have a third nerve, you have sixth nerve, fourth nerve, can they get damaged, or is the brain tissue damaged? So we did MRI studies, we don't see anything, but in fact, with the wavelengths we work and energy doses, it's very unlikely that we will get through the vessel wall into the brain tissue. But if you increase the power, and Tim can tell you that, you can blind a rabbit. So we have to be cautious when we treat these aneurysms that we don't go in that direction where we get damage to the retina. That can happen, not for the device we are working on, but laser in general. You know, lasers are used for other things. Then we thought, what happens when we use coils? So this is a coiled aneurysm, and of course, as expected, in 10 days, it was a single coil. The coil is compacted, and then there's some clot here inside, and the wires here on the cross section. What happens if we shine it with lights first, and then place the coils? We saw the same thing happening, coil compaction, because we used only one coil, and then there was this phenomena of the ribbon. You see here these lines. And then what we saw at 10 days already, endothelialization of coil. It tells us that we can use this technology with other implantable devices to create an early and complete healing. We need a matrix in front of the neck to make this work. Without that, it's not working. Now, to calculate energy dose and optical clearance for the laser, we use replica of humans. And then these are the photosensors, and they're now getting more and more complicated. So what we are doing is we are assessing basically how to improve and optimize the dose, the wavelengths, and energy and power deployed. So after we did all that, we went and did outside the United States, first patient. This is a patient with a middle cerebral artery aneurysm and a dysplastic vessel. This is the centering device with the tip of the laser. This is the marker, so the laser tip is somewhere here. We did, I think it was 5 minutes radiating time, and then we placed the fluid diverter, and this is 1 month follow-up where you see a tip or base of the aneurysm visible. So we have to see long-term data how that looks. This is an interesting case for 2 reasons. This patient has 2 aneurysms, a distal one, we call it supraclinoid, and then a bigger aneurysm down here. So the one with the red label was treated with laser, and the green one was not treated and kept as an internal control. And this is 1 month and geographic follow-up, and you see the aneurysm is already so small and you have a small neck left at 1 month after the treatment. People then ask, well, is that an ongoing process or it just stops at a week or two? This is a patient that shows you the challenge with this technology. This is an artery that comes out of the aneurysm. And we did laser therapy, we placed the flow diverter, and you see at 4 months, there is a little bit of a change. There's like a partial coverage here, there's some flow changes, but if a main artery comes out of the aneurysm won't close. This is an MRI follow-up at 8 months. The aneurysm is smaller, but it's still there. Another case showing you the laser treatment here, and then placement of the flow diverter and 5 months follow-up. Aneurysm is closed, some fish mouthing of the flow diverter down here, as we see in some of these devices. This is showing you at 9 months, stable occlusion that comes up with the FDA also. Is that a phenomenon that's short-lived, or is there stable occlusion of the aneurysm? And you see here that the aneurysm at 9 months now is still occluded. Another aneurysm in the A1, A2, laser treatment, placement of the flow diverter, and you see a little bit left here at 3 months, and we bring the patient back at 6 months, and the aneurysm is completely occluded, and the parent vessel is not narrowed. So we don't see through the signaling process any adverse hyperplasia so far. This was a more challenging case because of the deployment of the flow diverter. It didn't seal the neck, but you see at 3 months already, there's a little bit left of the neck of the aneurysm. No damage to perforators that comes up. And then at 6 months, there's still a tiny bit of the aneurysm left here, and otherwise the aneurysm is closed. So you see there is an expedited healing and closure soon. Another case, and then I'll wrap up, where we have placed the laser inside the aneurysm. This was the longest radiation time at a total of 20 or 25 minutes. And that's why we are working on the, thank you, 2 minutes. That's what we are working on the increased power, so we can reduce the radiation time. And this is 3 months follow-up showing the patency of parent vessel and the side branches, and the aneurysm is completely closed. In this case, the operator used a single coil. Now, we have looked into other things where this technology will be helpful. We have developed a way of combining the laser with a dye, color dye, that creates a middle meningeal artery occlusion, which, as you have heard, may be helpful for chronic subdural hematoma. We do believe that the laser technology will be helpful for stroke and traumatic brain injury rehabilitation, especially in the penumbra area, because it will probably address the neoplasticity. There are early studies going on from Stanford that show that there may be an impact on neuroplasticity by using light and electromagnetism. Now, laser is not new. Like I said, the capillary hematomas are treated by plastic surgeon, birthmark of the lip here. After laser treatment, the ulcers in the foot, gum ulcers and lip ulcers. So nothing new. So different wavelengths, it's external, it's not internal. So we have more challenges definitely to travel in the vasculature. I want to thank, of course, the Lilly family for all what they have done in helping us. I want to thank your boss here and my host, Dr. Handel, for guiding us and helping us through this, and Barry Lieber, Tim, all the executive team members here, and other physicians who have been very, very helpful in pushing us and also guiding us where this technology can be helpful. So in summary, I think the preclinical studies are promising, and they're showing us that laser light, different wavelengths, and energy can X-ray complete healing of experimental aneurysms or preliminary clinical studies, and we're starting a safety study in summer of this year. Shows that there is usefulness for PBM, and I think we are working on different probes for different applications. This is still R&D. But the laser itself that is used in the aneurysm, and we have to stay laser focused, needs some fine adjustment to fasten the healing response and translate the findings to the clinical data. Thank you, and what I have to give up.
Fascinating work. Thank you, AJ. Anybody, any questions?
In those patients who have some residual aneurysm, is there any role for recurrent laser treatment?
Thank you very much for the question. So our team, Tim is in the back, is working on a system. So this came up, I think 2 years ago, a year ago at this meeting, that immediately asked, what about if the residual aneurysms after flow diversion or after other treatments? We think that we can address that. We are starting, in fact, end of this month in Salzburg, our early R&D studies with that concept. Can we shine the light inside the parent vessel and treat coronary stent? In my case, I'm taking still Brilinta and aspirin, and I have to say, Brilinta is rat poison. I was playing tennis the other day and pulled one of my tendons, and I must have lost like a liter of blood. It was hypertensive. So we want to get rid of that for the coronaries, for the brain, for carotid stenting, where we can get an endothelialization. And I'm hoping that OCT technology, we must heard about that yesterday, that OCT technology will help us guide to understand when a complete endothelialization in a patient is completed. So to your question, yes, it's a very important aspect, and we are driving that at the R&D level. Any other questions? Oh, it's great to be here, and thank you very much.
Thank you. Do we have Professor Matuk? So we had a little change in the program and a nice surprise for everybody. We just started a new journey of hydrocephalus treatment. And Charles Matuk, professor of neurosurgery at Yale, kindly agreed last minute to give us an update on an international trial that is ongoing for assessment of this a new tool called eShunt. We have, is Charles there? So, and Charles gonna show you that, but we've been treating hydrocephalus the same way we did eShunt for God knows how many years. And it was super clever. He was here before with us last year before, Ed Malik and Carl Hyman from Boston. I think a brilliant idea of developing a biomimetic simulation of a rectal granulation that is implantable through a vein. So we have done cases here at Baptist, one of the sites for the study. So Charles is going to share with us an update on the clinical trial being randomized DP shunt against eShunt. I think we're going to learn a lot. Oh, for more than a minute.
We're about 1 minute out, you need to relog back in.
Okay, so another minute.
We need to.
Oh, yeah, sure. Housekeeping.
Yeah. If you're a nurse, please don't forget to complete your evals. Today is the last day, so I want to make sure that I complete that so you guys can request the CEUs. CMEs, you have a QR code as well in there. Make sure, so if your physician or ARNP, you guys need to scan that QR code specific. We still have one basket available, so hopefully we have a great winner today. And I think I run out of things to say.
Just a reminder, we have 2 exciting talks after lunch. I'm gonna cut short, so I know after lunch people may get tired, but please come back. The talk, especially Mark, is very, very exciting.
So Mark is going to talk about future of stroke intervention, and then we have a talk from Toronto live about robotics for neurointervention. Well, you put on your slide photobiomodulation for Parkinson's. And what do you mean?
So we think that certain degenerative disorders, including Alzheimer's and Parkinson's, may be a decline of, production of dopamine because of reduction of the cells, like a death of the cell. And we think if we could activate those cells before they completely vanish at a DNA level to produce and to first of all produce dopamine, but to proliferate and differentiate. That's something we have to learn. We know that from my studies that mesiotemporal lobe, when you do erythropoietin stimulation, that there is a possibility for nerve cells, which is unheard, that they can migrate from the dormant stage and duplicate. There was a study in Nature a while ago. And we think that laser therapy could address that. We're not sure. And as you know, we are working on the CSF transfer mechanism in DNA, and this could be added to that. So hopefully.
Sky's the limit. Charles, can you hear?
Did you see my screen this morning?
Yeah.
That's so weird.
We hear you. Hey, Charles.
Hey, how's it going?
Good to see you.
Alrighty. I cannot see you guys, but I'm gonna see if you guys can hear and see me.
We hear you, but we don't have your screen yet.
Try to share my screen. See if that works. Okay. There you go. Can you see that?
Yes, yeah, I introduced you a second ago, but thank you very much for doing this last minute. We're looking forward to learn about where we are with the STRIDE study. Dr. Matuk is the international PI for the STRIDE study. Thank you, Charles.
You guys hear me?
Yeah.
Yes. Yes.
Alright. With Chris Kemp, who's been great. I cannot hear or see you, but it sounds like you can see my slides and hear me. If that's the case, it's a pleasure to be with you. And I appreciate the invitation. I'm parachuting in at the last second here. We're super thrilled to have Baptist Health in Jacksonville along for this ride. You have an amazing program. And we're so thrilled that you've accepted an invitation to be part of the study. So yes, thank you to everybody, in particular, Ricardo and his team for doing such a great job. I'm going to give you a quick overview how I think about NPH in the next 20 minutes or so. I'm completely conflicted in every direction, but I don't think it should impact what I'm going to say today. But there are all my disclosures. So in terms of normal pressure hydrocephalus, to level set for this audience, there are some things in medicine that we absolutely know the diagnosis, right? So if you come in having chest pain and you do an EKG, and your troponins are high when you do blood work, it's pretty clear that you're having a heart attack. Or if you have low or high sodium levels in your blood, then it's pretty clear that you can do like a blood test, compare it to a normal range and get an answer. Most conditions in medicine, though, are not so straightforward in terms of the diagnosis, and NPH falls in that group of conditions. We give it a rubric called clinical radiographic syndrome, which means that it's a condition that has to have a classical clinical triad. So that's illustrated here, of urinary frequency or incontinence, some cognitive issues that are often mild, and gait instability, often characterized by difficulty getting up out of a chair without use of your arms, and then difficulty catching your balance once you're up. So if you have that classical clinical triad, a doctor will often do some cranial imaging, either a CAT scan or an MRI, and they'll see that the ventricular space, the CSF, sort of like containers in your brain, will appear to be distended or larger out of proportion to the amount of brain that appears to be lost. Because you can get brain atrophy, which will look like you have large ventricles, these fluid-filled spaces, but this is a relative preservation of the brain tissue and these larger ventricular structures. So if you have this combination of a classical clinical syndrome and you have large ventricles, and then the next step, then we call you as having suspected normal pressure hydrocephalus, and you have to do provocative testing to establish the diagnosis with certainty. So that's usually in the form of either a large volume spinal tap or a lumbar drain. And if you have a positive response, meaning that your walking times improve, then we say that you have this condition called normal pressure hydrocephalus. So normal pressure hydrocephalus has a storied history in neurosurgery. There are people that don't believe the condition exists. I think Ricardo and I, when we trained in neurosurgery, were told to hate shunts. We were told to hate hydrocephalus. And there was sort of always this sort of shadow about whether or not it exists. When I got into clinical practice, I ended up seeing these patients because nobody else wanted to see them in our practice. And the standard treatment, the classical treatment for this condition is a ventricular shunt. You see that illustrated over here, where you have to drill a hole in somebody's skull. You pass a long plastic tube through the brain into that fluid flow center, and then you pass under the skin a long plastic tube that you dump in some sort of fluid absorbing container in the body. And that can either be possibly it's the peritoneum, but you can also put it in the coverings or the lining of your lung. You can put it directly into your internal jugular vein and flow it down into your heart, but some space in your body that absorbs fluid. And it's a relatively straightforward surgery, but it has tons of complications, and often patients don't want a hole drilled in the head, especially older patients, which is the patient population that's affected by this condition. So I wanted to show this very quickly here. This is one of my first patients that I treated with a ventricular shunt. This is shown with the permission of the family. But what you see in this first sort of picture is an elderly man that's being held up by his two adult sons and trying to walk out the door. And you can see a lot of the features that we associate with the gait of normal pressure hydrocephalus. So the patient has a lot of trouble walking. He has like magnetic gait. He has trouble initiating a step. He can't stand really unassisted. And his two adult sons have to sort of help him even to take a step. So this patient then had brain imaging, had large ventricles. We did a spinal tap. He had significant improvement, and we placed a shunt. And this is his office visit 1 month after the shunt was placed. So he's able to stand up now unassisted. He takes up his cane. He's just walking out the door. And no one would say that his gait is normal, but I think also nobody would argue that this hasn't been transformational improvement for the patient and his family. So let me just do that. So now he's like showing off, right, holding the cane in his hand. And it's really been usually, very impactful for me to see this kind of improvement in patients that have this condition. It's very important to level set, right, with the family and the patient, because these patients are not gonna go back to normal, that's not possible. But you can definitely make these patients significantly better, especially if the issues are with their gait and their bladder control in particular. So when we talk about this condition and whether or not to work it out and treat it, it's entirely in terms of quality of life. And if I'm having a discussion about treating a brain aneurysm, it might spend something like half an hour in the clinic. But these conversations will often take close to an hour or even multiple visits to make sure that we're all on the same page about what to expect after the procedure. So if we have a condition and we have a treatment for it, what's the problem? Well, the big problem is that these shunt procedures have a high number of complications despite being relatively straightforward surgery. So one of our fellows a few years ago looked at the National Readmission Database. So these are all shunts that were sort of like placed over the course of a few years, and looked to see whether or not a patient was readmitted if they had a shunt or normal pressure hydrocephalus. And they found that up to 20% of patients were readmitted in the first 90 days after a particular peritoneal shunt was placed for NK. So that's an extraordinary number. And the reasons for readmission were often mechanical failure of the shunt, infection associated with foreign body, or a terrible condition called overshunting, where patients initially often feel better because their shunt is working, but it's almost working too well. And the brain pulls away from the skull and creates these fluid collections that then also compress the brain. That often requires removal or tying off of the shunt, and often operations on the fluid collections to relieve the pressure on the brain. And often that's a lot for an elderly patient who's often frail to undergo multiple general anesthetics and surgeries. So it's really a terrible complication and often leaves them worse than they were, before you met them. So come along these two doctors at Tufts University. So Carl Heilman, who's the immediately prior chair there, a skull-based surgeon, and Dr. Al Malik, who is their head of neurovascular surgery. And they thought, can we recapitulate essentially this thing called an arachnoid granulation, which is a connection between the CSF pocket of the brain and the venous circulation in the brain where CSF is absorbed. So in general, CSF is made at a constant rate, about 20 to 25 cc's an hour in the center of the brain. And that CSF then gets out of the head by being reabsorbed into the bloodstream. And it does so across this structure called an arachnoid granulation. And so what these two doctors, neurosurgeons in Boston, sought to do was to recreate essentially this connection in the brain and the venous circulation. And this is what they came up with. And this is actually the E-shunt. And what the E-shunt is it has this sort of like crown-looking structure, which sits over the opening and in a silastic piece of tubing. It's extremely thin, not much bigger than, if you have if your daughters have, those hair combs. I don't have much hair anymore, but, it's about the size of like a hair comb bristle. And this will extend. So this sort of crown thing sits in a CSF pocket at the base of the skull. There's an opening in the tube over here. And then at the bottom here, there's a slit valve, so a little slit in the tubing where the CSF can drain. And this part of the shunt, the distal end of the shunt, sits in the top of the internal jugular veins on the venous system. And this mechanism will allow for about 10 cc's an hour of CSF to flow from the CSF space into the venous circulation at about 5 millimeters of mercury of intracranial pressure. And the design of the slit valve means that if you have like a Valsalva maneuver, something that increases the venous pressure in your central system in your body, that you don't get reflux of blood into the head. So it's a very elegant design, and obviously much smaller and less invasive than a traditional shunting system. It's a very innovative sort of like technique, completely transvenous from a transfemoral vein approach, in which the E-shunt is implanted at the base of the skull. And so catheters are sort of like placed from the leg all the way up through the body, and then parked in the big vein in your neck called the internal jugular vein. The internal jugular vein has two branches, this larger branch, which goes up into something called the sigmoid sinus, and a smaller branch called the inferior petrosal sinus. We take advantage of this natural curvature at the skull base in the inferior petrosal sinus to deflect a needle, which is in the distal end and can be unsheathed of the delivery catheter. And because it's hard metal, as it comes along its angle, it's going to be deflected off its trajectory in the IPS. And then you can push this whole system forward into the CSF space at the base of the skull. And it's through this delivery catheter that you can then deliver that e-shunt, the crown of which will sit here in the CP angle-cistern in the CSF space. And then the long plastic tubing will end here at the internal jugular vein. And that is the full shunt mechanism. So you don't have to cut your scalp, you don't have to drill a hole in your skull, any of those kinds of things. So patients are very much attracted to it, as they should be, because it's much more minimally invasive. And theoretically, shouldn't have any of the issues related to infection, because it's such a small foreign body. It's a transvenous approach, very hard to get intravascular infections often with these types of very small implants. And because the gradient by which CSF gets out of the head is physiological, it's almost impossible to get an over-shunting syndrome. So it really addresses these two major concerns, which are the cause of early readmissions after VP shunt surgery. As a proof of principle, the first procedure that was done in a human being was done in Buenos Aires, Argentina, by Pedro Lillich and his team. And this was a patient that had hydrocephalus for another reason, subarachnoid hemorrhage. And this patient in particular had a drain in their skull, which was draining the ventricular space, not through a shunt, but rather into a bag at the patient's bedside. It's called an EVD, or external ventricular drain. And normally your pressure should be sort of like in the 8 to 15 range, but this patient's pressure is because they had an obstruction in a sense in how CSF was able to access the venous system. The pressures in the brain were actually quite high, so 35, 40 centimeters of water. Once the e-shunt was implanted, you can then continue recording the intracranial pressures, and you can see here, really within minutes to hours, the ICP dropped precipitously and stayed down for several days afterwards. In this patient, for example, the EVD could be removed without having a place to shunt in a sick elderly woman. So this was a fantastic proof of principle that an e-shunt actually did what it was supposed to do, which is to drain CSF internally without the need of a shunt, and to manage the patient's raised intracranial pressure in this case. He's since done this several times, and it seems to be a consistent phenomenon across patients. So good for Pedro. In the US, we briefly had a subarachnoid hemorrhage trial, but that was difficult to run for a variety of reasons, and the company settled on normal pressure hydrocephalus, which was also being treated in Buenos Aires concurrently. And you guys were actually great enrollers in the safety and feasibility study for e-shunt and NPH. So, congratulations and thank you for all that amazing work. Patients then got the implant. So we were the first to do this back in 2022, but you're part of a very elite group of the first people to do this in the country and the world. Again, we thank you very much for that. When we look at the results, and we're still collecting all the follow-up data, it's been extremely encouraging. So we follow patients, it's going to be up to 1 year, but at 90 days and 180 days, we can see here that their timed up and go test, which is an ambulation test, stays improved in a majority of patients. Their MOCA, interestingly, also is improved, as both this is a bladder control score, stays improved over the course of 180 days. And so we're just extremely excited that we've had such positive early results and has helped many of these patients, ambulate better, potentially stay in their homes, and improve quality of life without needing to have this much more invasive and complicated surgery. So just to ground everybody, this is a patient that from our practice that had an e-shunt, a lot of trouble getting up, sort of very classical. This magnetic gauge, short stride length, short step height, and a lot of difficulty with turns. Many patients will often grab onto a system or a wall or a chair or furniture nearby, so you'll see them sort of like go through their homes, sort of like grappling onto furniture. And a lot of difficulty sitting down, and these patients are obviously at high risk of having falls, breaking their hips, hurting themselves in other ways. Here he almost fell down. And this is 1 month after the procedure. So again, he's not normal. He's not nearly as good as he would want to be. But I think again that it's difficult to argue that this isn't a significant improvement in terms of the stability, the smoothness of walking, the speed of gait, and the confidence that he has that he's not going to fall and be able to sit down normally. So again, very important to manage expectations. When you're talking to these people, just if your team's there, Ricardo, to remind people that they're not going to be normal, but that they're going to be better, and that the better is going to be meaningful, but probably not as good as they want, because everybody wants to be normal. So have we had complications? Thankfully, they have been very few and far between. And the main complication that we've seen, thankfully, is transient. That has to do with double vision. That occurs in about 10% of patients and tends to last anywhere from 1 to 3 months. Thankfully, all cases that we've had, I think that Ricardo's had, the high volume center, as well as the group in Buenos Aires, have been transient. And so we haven't had a case of any kind of permanent cranial nerve 6 palsy. This likely has to do with where we place something called an anchor, which is how we get the E-shunt into position. And we think it has to do something with anatomically the fact that there could be stretching of this very long cranial nerve as it passes under a ligament at the skull base. Injury to the IPS or the internal jugular vein is extremely rare and should not be an issue clinically and hasn't been to date in the overwhelming majority of patients. So here we are now. We are at the point where we've shown that implantation of E-shunt is not only feasible but safe, and we have a tremendously exciting signal that we think is effective. And so the study that is now going to show is called the pivotal study that E-shunt is not inferior to VP shunting, is called the STRIDE trial. And so the way this is going to work is that you guys are currently enrolling in STRIDE. The way this is going to work is that you're going to have patients come in that you think have NPH. Then you're going to do the lumbar puncture, and you're going to assess for their gait speed and improvement after a spinal tap or 3-day inpatient trial of lumbar drainage. If they pass on that criteria and they have large ventricles on their imaging, then they pass to the next step, which is they get like a fancy MRI scan and a high resolution CAT scan to make sure that their anatomy is suitable for implantation of the E-shunt. If they have a convincing clinical radiographic syndrome and they have improvement in their time duct and go test, and they have anatomy that's favorable to implantation of the E-shunt, they then get randomized between a traditional VP shunt and the E-shunt. And then we follow them out to 1 year with the primary endpoint being 180 days. And really what we're looking for is to show that the E-shunt provides similar benefits, so it's as effective as a VP shunt, not inferior to VP shunting in terms of efficacy, in particular improving their gait speed, but that it can do so at a much better complication profile. And that is the study, and we're super enthusiastic that we're up and running in a few centers already, including at yours. And we super appreciate your involvement and are super proud that we were able to convince you guys to participate in the study. So I'm going to say thank you because I can't hear anything. And I'm just going to see if...
Can you hear us, Charles?
Oh, I can hear you now.
Awesome, awesome. Thank you, man. Really appreciate it. We really appreciate. How many patients enrolled on the study this far?
It's just a handful in STRIDE now. I think there's like maybe 5 today.
Awesome.
6 maybe with 1 shunt.
Great.
So you guys are right in the thick of it, and I expect you guys will be super high enrollers.
Yeah, so I wanna use the opportunity to say, thank you to, PHRI team, I see Jefferson there, I don't know who else is there, but, they have been instrumental. Jefferson is our gatekeeper. The company has done a very nice job in, letting patients know that the sites that are available, so Jefferson is screening patients from our region, to come and be treated at Baptist with Eric, me and, the team. Any questions for Professor Matuk, guys? Here's AJ, Charles.
Hello, Charles. First of all, thank you for a really beautiful overview of the subject. Quick question regarding, do you need, because the one part of the e-shunt stays in the venous system, you need anticoagulation? And the second thing is, when the pressure is not elevated, since there is no dripping of the fluid going on, is there a risk that several elements may block the e-shunt?
I think those are great questions, Ajay, and yeah, thanks for asking them. I hope to connect with you soon. To answer the first question, there's so little, the device is so small that we haven't gone to a protocol that involves anticoagulation. We do anticoagulate for the procedure itself, but we have not placed them on post-procedural anticoagulation. And we have not seen any issues with thrombosis in a delayed fashion, you know, from the e-shunt implant, which is great. But I think that has to do with just how very small the implant is. With regard to the second, I think there's like a bit of an open question. As the pilot study had a minimum opening pressure of 10 centimeters of water, that was lowered to 8 centimeters of water. I would say that we don't know in general, even after VP shunt, whether differences in opening pressure are translated to different benefits or amount of shunting with either standard shunting or e-shunting. But I generally agree, and I think the companies agree that you do have to have a gradient, right? And so you do have to have probably the better the gradient, you know, the better this thing is gonna drain and hopefully stay open. But delayed blockage is a theoretical concern. I think we're just gonna have to wait and see how that pans out. Thankfully, the majority of patients have had sustained benefit over 1 year that we followed that long, and so that's encouraging. But we have had patients where the impact has waned and where VP shunts have been placed in a delayed fashion with renewed improvement in the patient, inferring then that there has been a blockage or malfunctioning of the e-shunt in a very small minority of patients. So I think your point is excellent and well taken.
I have one more, Charles, unrelated to e-shunt. You got a nice cover on neurosurgery a couple of months ago on lumbocavo shunt. How do you guys name that? Can you tell us a little bit about the technique? How do you do that?
Yeah, you bet. So, and thank you for Ricardo for even like looking at it. I appreciate it. It's sort of only been adopted, I think, by a handful of patients, and we're still learning about it. The idea was born just briefly from, I was getting referrals for difficult to manage IIH. My practice is just outside of New York City, so often from the city. And these are patients that had had like 15 or 16 shunts that were placed over the course of time for idiopathic intracranial hypertension. They didn't have transvenous gradients, and so the idea was that these patients were probably unlikely to benefit from being stenting, and often had papilledema and vision loss, or had refractory headache syndromes. So they came to me looking to place an e-shunt because we were one of the first in the country to be doing it, and that's how the referral started. But many of those patients turned out to be anatomically unsuitable for e-shunt, even on compassionate grounds, right? So you have to lobby the FDA to use this on compassionate grounds. And so we were trying to mimic the function of an e-shunt using stuff that we had. And so the idea was then and these patients often have split ventricles, so we wanted to get it out of the head. So then we thought about the back. And then we thought that we wanted to have a very low pressure receptacle. And so the venous system, especially close to the atrium, has a very, very low pressure. And as opposed to, for example, the belly, which is traditionally where lumbar shunts are placed, we decided to put it into the femoral vein of the leg and then to float it up into the right atrium from below. And it's been an iterative process of like learning that we have to anchor the lumbar catheter, learning that we can't make the catheter that sits in the vena cava too long because we don't want it to flip into and across the valve, the ventricle, because it can cause irritation. We've learned, for example, that patients that have very high pressure gradient differences are probably a bad choice to use lumbocable shunts because if your pressures are, let's say, in the 60s in your brain, that the differential is too great, you can get brain sagging and downward herniation. But the majority of patients with IIH have pressures in the 30s, and this gradient seems to just be very effective at managing not only their papilledema, but also the refractory headache syndrome. And so often if patients now have headache dominant IIH, real IIH, but it's not causing papilledema, it's manifesting more as this headache that gets worse when they lie down, and their lumbar pressures are like in the 30s or high 20s. I'm putting in these lumbocable shunts as the first choice option, and they seem to be very well tolerated, and we've been very happy with the results. I hope you use it once or twice and tell me what you think.
Oh, we're looking forward to patients, I'm sure they'll come. Anything else, guys? Oh, Eric is asking, if your Canadian brother is asking, from Canadian to Canadian, valve or no valve?
So we do place it, so from the 51st day, we do place an anti-gravitational unit that's over the abdomen. So there's no valve per se, but we do add a gravitational unit so that when they stand up, they don't pour out. So it's a fixed valve.
You're in New York now, so you've been from the 11th province, correct?
Anything else, guys? I think we're gonna break for lunch. Charles, thank you very much for parachuting and enlightening our thankfulness. Thank you. So we'll be back at 1 p.m. sharp, guys. Enjoy your lunch.
Pressure. When the pressure, it'll like open up a little bit.
Testing, 1, 2.
When I do have a little like that, I believe that. That was like my guess.
What did you want, Carol?
Anything, whatever.
Yeah, go get another piece of chicken.
Yeah.
Okay.
So I'm just waiting for like.
Yeah. Be your fair share of, yeah. More about, yeah. Okay, my lead is right here. Okay.
I'll put that down.
Yeah. Out here, or no? Yeah. Where? And sorry.
They don't have any out here, so there's no TV there.
Oh, probably in the room, the first room, vendor hall. Oh, maybe. Yeah.
I'm trying to still hit on there. That's good to pull it out.
Oh, let me say one thing. I just sent them out for my husband.
What you think? Pretty fun day, huh?
Yeah. Enjoying the information. I don't. So I saw the dog thing. And I saw what I thought about it. I'm like, I'm gonna tell you that. I said, my feelings from bothering. Huh? You're from Boston?
That's why.
The next time you can. It's good.
How are you, Dr. John? How are you all colleagues?
Hey, how you doing, Omar? Hold on. I'm trying to get. Hold on. Trying to get. I'll talk to you later.
No.
How you doing?
I hate to stop the socializing. 2 more talks and then we'll socialize the rest of the Friday.
Okay, we'll talk later.
Next talk will be Dr. Rebo again.
Okay.
Talking about new frontiers in acute stroke treatment. Let's see what our Spaniard friend has to bring to us.
You know, I can't hear you too well. You can text me after the meeting, okay?
Still, only recorded, but let's talk now about what is going to be the present and the future of our stroke treatments in our communities, in our countries, regions, and how can we lead the thinking here in this health that is stroke, and how the stroke specialist that is looking at this doctor is going to lead us to improve the future. First, I want to show you here how thrombectomy was marketed and shown 15, 16 years ago in this TV show.
Injecting. Cross your fingers. Three. Chasing. . . . . . . . . . . .. .. .. .. .. .. .. .. .. .. . . . . .. . . . . . . . . . .. .. .. . . . . . . . . .. .. .. branches.
So yeah, they forgot to put their hats and the masks, but that was the nursing device. That was supposed to be fantastic. That was supposed to cure stroke. It was all over the news. A few years later, we showed that we can have better devices, centrifugal respiration catheters. That the results, this device was abandoned. But anyway, it was very, very fashionable at that time. We are growing our number of thrombectomies. We are reaching more and more people at different speeds. We're growing, but our objective today is to make the heights faster, the bigger coverage, the better coverage to the population. And for that, we need to know what to expect for recovery. If we want to cover only our LVOs or the MIVOs also. These are the numbers that you should be doing in terms of thrombectomies in your center. Your center covers 100,000, let's say 1 million population. You should expect to do 240 thrombectomies per year. And so everybody should know what is your catchment area. If your catchment area is 1 million and you want also to treat all your MIVOs, then you should be doing around 440, 450 thrombectomies per year. So obviously most of us are not there, but yeah, at least we have a goal. So we know how far we are from this goal. Progressively, we need to get closer and closer to this goal with the several measures. All the models are telling us that in the future we're going to do more and more thrombectomies. Hopefully, we're going to be in this scenario in which we grow faster and faster, and we can help more patients. Now, to be a vascular neurologist, because of all this fun and all this excitement around such a powerful treatment, is growing. And year after year, you have more candidates that want to become stroke specialists. And if you are a resident and you are doubting, I would strongly recommend you to dedicate your career to stroke. It's very rewarding. We're helping a lot of people, and the future is nothing but bright and full of opportunities. Now, what happened before we finally proved that thrombectomy works? So over the years, in the region where I work, in Catalonia, we were treating around less than 300 patients per year. And in 2012, there were 3 large trials showing that thrombectomy is not helping our patients. They were not well designed, we did not have the correct tools. And then we decided that we were strong believers in this treatment, and we needed to do 5 trials were done in the world. In Catalonia, we did Cerebrovascular, and it was a big sacrifice to randomize patients with proximal M1 occlusions, young patients, in which we were convinced that the treatment works, and to receive best medical treatment, right? They were randomized, and all these patients here right now, they could have received a thrombectomy, and they did not. And so it was a kind of sacrifice. But because we did Revascat and a few other trials at the same time, and they were all positive, because we had this equipoise. We forced ourselves to enroll comers with the inclusion criteria that met the inclusion criteria. The next year already, we observed a substantial increase in the number of treatments, and a few years later, I had to change the scale. But now, in my region, we're treating 4 times more patients, and this is because we had this, let's say, sacrifice of patients that probably would have benefited from thrombectomy. But in order to show to the world that this works, we had to include them in trials. So it's important sometimes when you participate in trials to think about this and not to lose your equipoise. Try to recruit all comers. Otherwise, we will still be doing 300 thrombectomies per year. Anyway, for many years, in 2018, when Dawn and the few saw that you can treat patients in a delayed time window with CDP criteria, you have been working with this mental set, right? place CT and CTA the first hours, and CDP to select patients in the daytime window. In 2002, only 2.5 years ago, we finally proved that thrombectomy works for the posterior circulation, which is something crazy, right? And before that, we did not have strong evidence. And now that year, then we have 2 trials showing that we finally can say that thrombectomy works also for the posterior circulation, and it is only for 1 year, since last year, listed as class 1, not level A, I don't know why, but class 1 evidence that thrombectomy works in the posterior circulation strokes also. And this is our role now as a stroke specialist, to spread the word and that no basic arterial occlusion patient is not treated without thrombectomy. They're really helping. So we try to see the limits. What are the limits in terms of initial aspects or the time window? How far, how low can we go? This was addressed. How low can we go in terms of aspects in large score in several trials that were published 2-3 years ago. The most representative is the last trial that included patients with a very extensive aspects down to 0. Let me show you the results. Those patients received best medical treatment or thrombectomy, mechanical thrombectomy. On arrival, they have huge infarcts, 150 milliliters of core, which is very big. And despite that, those who received mechanical thrombectomy did not continue to increase the infarct volume that was bigger 24 hours than those who did not receive mechanical thrombectomy. So we are saving a lot of infarct here with thrombectomy, even with a large course. It is safe to do that, and symptomatic intracranial hemorrhage rates are very acceptable, not higher when you give mechanical thrombectomy. And the most important, many times people would say, no, I would not indicate thrombectomy in a large core because I'm going to create a long-standing vegetable state patient with an MRS of 5. Look at this. The good news is, independently of what is your treatment, you're not increasing the rate of very severe stroke with an MRS of 5, not even MRS of 4. The only thing is that you are switching deaths for MRS of 3s. So you have more good outcomes, the same amount of alive patients with very poor outcomes, and less deaths when you give thrombectomy to patients with large cores. And I'm going to show you here the mortality occurs first in the first hours or days, but it stops when we receive mechanical thrombectomy, and it continues over the next 3 months when you did not receive, or 6 months even, when you did not receive thrombectomy. And the impact, the positive effect is independent of the age, same with older and younger patients, same regardless if you received or not IVDA, and even in the late time window, and remember the trial went up to 7 hours, still in the 4.5 to 7 hours, the treatment effect, the benefit of thrombectomy was the same in these patients with very large scores. And most important, the last included patients with an aspect down to 0. And even if patient had an aspect less than the 3, 0, 1, and 2, the treatment effect was exactly the same and was positive. So we should consider thrombectomy in the first 7 hours with patients with huge cores, with aspects down to 0. This according to the last trial. And this has shown to be cost effective. And why is this? So that many, at least in Western countries, there are many studies showing that thrombectomy is cost effective again. And why is that? Because as I said before, you are not increasing the number of severely disabled patients. And these patients that will be eventually dying at 90 days with the best medical treatment, during all these months, the first months, they are going to be severely disabled. They are going to end up dying because a death is cheaper, but a death delayed to 190 days or 90 days is very expensive. So on top of that, on top of being effective, thrombectomy is cost effective in the with low aspects. How big telescopy? So again, already in standard outside of the trials, we can see the same trends. Patients that receive thrombectomy, even with aspects 0, 1, and 2, they will have better chances of having less disability, and especially if their age is below 18, or again, at least within the first 6 hours. We don't really know what happened with these very low aspects after 6 or 7 hours, but for sure, in the first hours, they should be considered for treatment, because all the data shows us that we should be doing it, right? So the effect is even sustained after 1 year, and this we have seen in the SELECT trial. Large core patients have not only better outcomes in the first months, but the benefit is sustained at least after 1 year. Also, what happened to tunnel visions and large strokes? Same. There is a debate, should we stand or not? It seems, again, here, if we stand them, it is better to stand in the carotid artery. We are helping these patients. So the fact that they have a large stroke doesn't mean that we should not be putting a stent in the carotid artery. The first pass effect that we know very well for thrombectomies is still the same. No matter how we count it, 2C3 or 2B3, if you achieve that on the first pass in large core patients, you're going to have better outcomes. So the idea is try to choose your best thrombectomy method, whatever you think that works best for your patient from the first pass, because you want to have the first pass effect. And age, what about age and large cores? Of course, age is a bad prognostic. The older you are, the more deaths, the more bad outcomes you're going to have. However, look at this. Patients that reperfused, they have better outcomes, despite they are 90 or 100-year-olds, than those who do not reperfuse. So again, the probability of death is lower even at 100 years old when you achieve reperfusion. So the fact that the patient is old per se should not preclude at least considering thrombectomy, because without thrombectomy, the outcome is going to be even worse. So remember this. Yes, bad prognostic, but the treatment is still there in the age. What about anesthesia? There's a lot of arguments and pros and cons for anesthesia in thrombectomy. It looks like with large cores, putting these patients under general anesthesia may lead to worse outcomes, and especially because they have higher rates of pneumonia. So yeah, something the data is pointing towards. You shouldn't use anesthesia in large cores. However, this is only a single study, but interesting to mention here. What is the clinical relevance of intracranial hemorrhage in these large cores? So we see that very, very often with the performance thrombectomy, you see some kind of hemorrhage in 3 out of 4 patients. So it's very common to see some staining, some, I don't know if it is contrast of blood. What is the impact of that? So symptomatic intracranial hemorrhage is still very low, despite in all these trials, more than 50% of the patients had some kind of blood. Those that were symptomatic were very scarce. So we shouldn't fear symptomatic intracranial hemorrhage. And in any case, thrombectomy with no hemorrhage at all is leading to best outcomes. Medical management with hemorrhage, worse outcomes, but it is better to receive endovascular treatment with some kind of hemorrhage. You will have better outcomes than no medical management with no hemorrhage, with no hemorrhagic conversion at all, right? I think this is also interesting to mention. So you shouldn't fear hemorrhagic transformation with a large cores and thrombectomy. Maybe with lytics, of course, but not with thrombectomy. And all these trials led, in this case, yes, to class 1 level A evidence towards thrombectomy given within the 24 hours in patients with aspects down to 3. There's only one trial showing benefit in aspects 0, 1, and 2, but for sure, there's no doubt that aspects, low aspects down to 3 will benefit in the 24-hour windows. So remember this, and again, try to spread the word to recruit all these patients, use them, and give them the best treatments. Now, if you go back to this scheme that we have to select patients, these trials have shown us that in the late window, we do not necessarily. So first, we can lower our aspect here from 5 to 2 or maybe to 0, as I say. It is very frequent that in the first hours, you have patients showing these low aspects. In the 0 to 3 or 3 to 6 hours, and less than 10% of the patients that arrive to the hospital have a low aspect. So this measure applies at most to 10% of our patients. But the good news here, as I'm going to show, is that we are already benefiting our patients. We're implementing what you've seen in clinical trials. So here we have in my region the rate of aspects on admission. And you see that it is consistently 10% of the patients come with aspects below 5. Now, what happened here with the treatment? And until last year, we were not treating patients with very low aspects. And after publication of this trial, suddenly we are treating 10% of our thrombectomies. They are treated with an aspects below 5. So it means that we're doing our job, and our stroke specialists were transferring the benefits of clinical trials into standard clinical practice. And now patients are treated even if they have a low aspects. So what happened in the late time window, and Mr. Greenberg a couple of years ago was published, and they tried to show that you can select patients without CT perfusion, only by selecting patients with moderately good collaterals from CTA, not CTP. You can show again that endovascular treatment is better than the control group. So for the first time, we are showing that you don't need advanced CTP to select patients in the late window in order to indicate thrombectomy. So no need to have any more of this. And even with core volumes, with CTP, with core volumes up to 120, 130, yes, you don't care. They still have good outcomes, better outcomes with thrombectomy than without thrombectomy. This is with MRI, and so very large scope with MRI up to 140, still better outcomes. And it is not good what happens when you have massive, huge infarcts on MRI. With what happens with CTP, independently on the core measure of CTP, this big area, even if it's up to 150, you still see the treatment is the same, favors thrombectomy. So why do you care if the core is less than 70, 100, or 150? The patient will benefit anyway. Same with aspects. The patient will benefit with aspects of 5, 4, 3, 2, 1, or 0. So same. So we need to simplify imaging. You don't need in the early time window and in the late time window again. This is in the late time window. So no need to know if your core is 100, 150, you will have benefit as compared to best medical treatment anyway. What else? We can drop them as mandatory this advanced imaging in the late time window, and we can simplify our algorithms of imaging. And you can simplify them. You don't need to think anymore just by applying density and CPA to show an inclusion. Whatever the time from onset is, you can select your patients for thrombectomy. And you need to spread the word again. You need to work with your primary stroke center, comprehensive stroke center to make imaging protocols that make sense and that are not restrictive and that are easy to apply. And yeah, more and more we're seeing these kind of editorials in which we talk about imaging, and inclusion for thrombectomy is now the new default. We don't need to look for reasons to treat the patients. In many cases, we need to look for reasons not to treat the patients. So less is more in terms of imaging. We have been working with conventional CTs. This is enough to indicate a thrombectomy. You can see a decent aspect. You can argue this is an 8, 9, 7, whatever. You can see this hyperdense MCH, and you know that there's an occlusion. You don't even need a CTA, you don't need a CTP, you don't need an MRI. This patient with a brain CT, you can safely indicate thrombectomy, in my opinion. And therefore, why not to indicate thrombectomy instead of the conventional CT with a cordial CT that you can acquire in the antigen? Look at the difference. It's almost the same. Yes, maybe the definition is not exactly the same, but it's good enough to make decisions about thrombectomy, especially in the early time window. So therefore, our hypothesis is that you can transfer the patient directly to the anti-suite. Here at the EMS is transferred, so there's no switching the bed. Same as the ambulance is brought to the anti-suite. You put the patient on the table. Here, we're going to acquire a protein CT very quick before anything. You rule out the hemorrhage, and now you know that the patient has an NIH of 10 or greater, very high probability of large vessel occlusion, no hemorrhage. What else the patient can have? You're ready to start with thrombectomy 10-15 minutes after arrival to the comprehensive stroke center. So many advantages. Short door to run time. You may have additional advantages. I will speak about later. We performed this randomized trial in my center. We saw that you can reduce door to run time from 42 minutes, where everything is ready and go to the conventional CT. It took 42 minutes, which is great, but you can reduce it to 18 minutes. You almost save half an hour here by taking the patient directly to the angiogram. And we saw a positive effect. In the ranking. So we are trying to replicate this in a multi-center international trial that is called BITFAST. Anyway, most of our patients in my reality come within 6 hours from onset. We have shown that the impact of direct transfer to angiogram is highest the earlier the patient comes. After 6 hours, this reduction of 30 minutes will not have such a big impact, because the patient is either has a large impact, who was a fast recruiter, 30 minutes will not make a difference, or the patient is slow recruiter, and after 6 hours, 30 minutes more or less will not make a big difference. So fast recruiters in the early time window, 30 minutes count a lot, and you make a very big difference. And this is the patients you want to bring directly to your antigen. So we don't perform direct transfer to antigen in patients that come late after 6 hours, especially we do that with those who are admitted early time window. About repeating imaging for transfer patients, more and more we should be convinced that we shouldn't be doing that. We are harming patients if we repeat this image. So please do only repeat imaging if there was a substantial clinical change. If the patient suddenly feels very bad, or you fear that there was a hemorrhagic transformation, which is, by the way, very, very rare during an inter-hospital transfer. Or if the patient completely recovered and you think he recanalized, then yeah, it might make sense to. But otherwise, do not repeat image. Even after 3 hours from the first image, or 4 hours from the first time image you did at the spoke, and you still benefit the patient if you do not repeat image on arrival to the comprehensive stroke. So try to avoid this. Most of the times it will not change your mind or your procedure. You are still going to be doing the thrombectomy, but you are harming your patient. Another thing we should do as a stroke specialist is 132 minutes. I mentioned it before, but this is horrible. When the patient comes to the spoke, you need barely 30 minutes to identify that this is a potential stroke, do a CT scan, initiate thrombolysis, the patient is eligible, and put him back in the ambulance. You can do that in 40 minutes, 50 minutes, let's say, but not more than 2 hours. This is crazy. This is too much. And this is a clear point where a stroke specialist, we need to work in our networks to use this very bad indicator here. And we need to be ambitious. Here, these friends study, they showed that when we reduce time, transfer time, we improve. But it's not the same to reduce from 4 hours to 3 hours than to reduce from 90 minutes to 60 minutes or to 30 minutes. The degree or the impact of your measure is going to be much higher. So we need to be very ambitious and not feeling comfortable if you are in this area. We need to push towards the left as much as possible and do things very fast, because the more every minute you gain has a higher impact, the more you go to the left of the, right? So what happens with transfer patients with large scale? Another excuse we might hear, no, I will not transfer the patient for thrombectomy. He already has a large core. By the time he gets there, it's going to be too late. We're not going to help him. Look at this. The drop in the ASTER score is 0.3 points per hour was the SELECT trial. So it's declining slowly, yes. And the transfer time, median transfer time, was 3 hours SELECT2. Look at this. Even for transfer up to 200 to 400 minutes, you still have better outcomes with the vascular treatment than with best medical treatment. So even large transfer for large core patients, a long transfer for large core patients, and drops of the ASTER score up to 4 points, 3-4 points, still mean better outcomes with thrombectomy. So purely the fact that the patient has a large stroke on the spoke does not mean that you should not be transferring your patient. In the future, we'll be using probably AI tools to identify for the occlusion. These tools, you can combine clinical data as the NIH with the imaging processing to improve even more your prediction power for LPO. So this is going to be more and more used. So we can now predict the core. We don't need CPP anymore. You can, with a plain CT, you can get all the information. Where is the occlusion? Where, how much infarct is irreversible already? And it correlates very well with CPP maps, but the most important with the final infarct volume. So without contrast, you can get a lot of information. AA tools, you need to use them cautiously, and the FDA reminds us that it should help us to make our decision. It should not take the decision instead of the physician. It's just something that should guide us, but you have the final decision, and you should not be replacing the physician, as we should remember. And what happened in the very, very late time window? So in this study, we put a patient with time from onset up to 240 hours. This is 10 days, and you still can see that it favors thrombectomy, and you can still find at least a subgroup of patients in the very, very, very late time window that still benefit from thrombectomy. It doesn't mean that there's probably a selection bias, but you see the longer the time from onset, still there is still benefit, and we should be working in how to expand and how to make time more fluid and not such strict criteria. There are patients out there at 3, 4, 5 days that may still benefit from thrombectomy, and this happens in many parts of the world where the distances are huge, the awareness about stroke is big. There are very few thrombectomy capable centers. You need to travel long distances to go to these centers, and it's frequent that patients get there beyond 24 hours. We should find a way to indicate treatment in these patients, and maybe with simplified imaging, because most of the time these are developing countries where you don't have access to MRI, CT everywhere. Maybe we're going to be able to find with AI processing of non-contrast CTs the right profile of patients that will still benefit from thrombectomy in the later window where we are running this trial, and there are others coming. So CTP, is it still useful? For sure. It gives you a strong prognostic about what is going to happen with this patient. You should use CDP to include more patients, not to exclude patients. It helps you identify the patient that will benefit, as I said before, from neuroprotectant, and also it helps to detect MIBOs, smaller occlusions that are not very obvious on CTA. So you need to know how to use CDP. It can be a good tool if you know how to use it. Again, here we need to use our skills as strong specialists and to apply this. So these kind of conclusions, they can be overlooked on a CTA, and with the CTP, you're going to find more of them, and then you decide if this makes sense to treat this or not. And this takes us to the MIBOs. What should we do with this kind of conclusions? It is unclear. It is unclear mostly how should we, or even should we treat them. A few months ago, we have these potential scenarios that were trials that were about to be published. We have, for sure, we know that we should be treating LVOs, what happens with more distal occlusions, which represent a substantial chunk of our patients. And half of the LVOs would be, half of the volume of the LVOs would be M3s, PCA, ACAs, and other treatable arteries that are not considered LVOs, right? So it's a substantial number of patients. We have these scenarios. The trials could have shown us worse results with EBT, and this means we need better tools, better skills, better selection. Hopefully, EBT would show us someday that it's better than the best medical treatment, and still we need to improve, but it means that we have the correct tools, right? This is kind of the scenario that happened, and I'm going to talk about later, but we could also have this scenario in which, in one hand, you can help patients achieving better outcomes, but you can also increase the chances of symptomatic hemorrhage. And how do we address this? This is difficult, and thanks God we are not in this scenario, because it's difficult to address as a physician and to explain to the family that I have a treatment that may help a lot your husband, but on the other hand, it can also kill him, and you have to take the decision in 30 seconds or a minute about how to proceed, right? So these two trials published 2 months ago showed us that basically there's no clear benefit of giving thrombectomy to patients with medial vessel occlusions. It means that we need better tools and skills and selection, but it also means, if you analyze these trials, that we did not recruit the best patients. We did not have equipoise. We were treating those with higher NIH outside of the trial. So the trials really applies for patients with an NIH of 6, 7. Translating to the reality that we don't know if we try to go too far or too soon, or we just did not select the best patients for the trial and we don't have the correct answer. In any case, we need to consider in these patients what is the tortuosity, the caliber, and the distance. How far are we going? And when we make the selection, and if we could select according to the tortuosity, maybe we will be able to identify the right patients. We're working on tools with AI again that can quantify the tortuosity and the bending length, the tortuosity index, and we can identify those patients in which the tortuosity may be dangerous to catheterize. When we catheterize a tortuous vessel, we change the shape of this vessel, and look at this, only by going with the bubble 5, and we may rupture a bulging damage when we pull our stent material. So if there's very tortuous, it might be difficult to get good results. So maybe we can again in the future select patients according to this. This is a very distal occlusion that we didn't treat the right way, and we're pulling here the stent that creating a hemorrhage. So, and we need to have the good skills to treat these patients safely and efficiently. Anyhow, over the years, this is what happened in my region, Catalonia. We are slowly improving our skills, our devices, and more we have good recanalization outcomes, and more TK3s, TK2Cs, and less than 10% of the patients achieve a non-sufficient recanalization, TK0, 1 or 2A. But we still need to work here to reduce this red ribbon as much as possible. The more patients we diagnose, the more times we suspect an LVO, and no matter how with CP, CPA, CTP we diagnose an LVO, the more we're going to be treating patients. Where should we treat these patients? Yeah, this is also controversial. Do we need to treat them in the smaller centers in which less than 50 thrombectomies per year are performed? Are we going to treat them only in the very large centers? So it looks like the trend is towards, yes, we're still going to have these massive large centers that perform over 500 thrombectomies per year, but we need to work, probably in my opinion, in those medium centers that are strategically located geographically that can cover a catchment area that allows a decent number of treatments, and probably discourage as much as possible, sometimes it's not possible, but those centers that are treating very little number of patients. You need to have kind of accumulate expertise, right? And if it's not absolutely necessary for geographical reasons, not to have centers that treat a very small number of patients. And here again, we have to apply our criteria. Now, good and bad news. World Stroke Organization showed us that the prediction in reducing the stroke burden in terms of millions of deaths during the next 2.5 decades is good. We're going to reduce the million of deaths in the high-income countries, right? Yes, this is good. For the first time, we're bending the curve. However, fortunately, this is not going to be true for underserved areas. For developing countries, where still the burden of hemorrhagic stroke in general or ischemic stroke is going to continue to increase. More and more people are going to die because of stroke. So we need to spread the benefits of this powerful treatment and everywhere. This is an example of a thrombectomy that they recently did. The patient is hemiplegic here, he's anosognotic. Look at him.
Muy bien, ¿de quién es esta mano?
He's hemiplegic.
Esta, ¿de quién es esta mano? ¿De quién es?
He cannot recognize his arm, right? So very severe stroke.
A ver, levántalo.
We did a quick recanalization, almost complete recanalization. Few minutes later, he's.
Vamos a terminar. Levante las dos manos.
He recognized his hand. He
Muy
can
bien. Puede bajar. Ahora la pierna derecha no la mueva, pero la izquierda levantará.
Look at this, beautiful, right?
Muy bien.
So unfortunately,
Muy bien. Ahora yo cómo se llama.
Many parts of the world are not getting these benefits. And again, we need to work here to make this treatment accessible everywhere in all these red regions by all these improvements, with better selection, with better tools, with better skills, with faster protocols. We need to work all together as a network to achieve the best results everywhere. So thank you very much for your attention. I hope again you liked it. I'm unfortunately I cannot be with you, but hope you have a nice day and conference.
Comments? Or just an involved presenter, and I'll bring about issue, right? Chris? Dr. Nima, any comments? Or just
Yeah.
Mark, can you hear us? So question for you then. Okay. So I think this was a fantastic lecture. Questions about working for how often, even if we use deep learning algorithm and do pixel by pixel assessment of the CT scan. The dark field that we described on DWI, the change in susceptibility of the water, and how much really is a core infarct and how much is reversible. Because otherwise I cannot explain that after 74 hours, you can still save tissue. Unless there is a tissue somewhere that's about to die, but prolonged. But we really see what in fact is the body.
Like to hear Eric, but from my perspective, I think that during the talk I was telling AJ, how far we came, right, from being very selective for, and that's, I think, for me, a paradigm that we broke, that we don't know. Again, this definition of the non-report that we all put our hand on the start is, it's, again, see the patient that asks themselves, true walking and talking. It is 20%, it's not, but again, there's a lot there that we don't understand. That is reversible damage. What we thought was established is broken on CT and MRI. So I think it's fascinating.
At your base, Ricardo, do you do perfusion scan or you?
Our routine, when Eric and I moved to Baptist, we call this big brother of medicine, right? We have the largest footprint of rapid drug outbursts outside of Stanford, and we continue to do because it's very hard to turn on and turn off at the ER level. When to do CTP, when not to do so, everybody gets a CT, CTA, CTP. That is our routine, unless you're part of a clinical trial that you may change things a little bit, but. And we do see this, and Mark will beat us to the punchline that we're seeing this post or before the CTP that doesn't mean anything. So I think this day and age, we got to open it as our best if we rely on the age, regardless of the aspect. Something on the quality of that on the CT, or we'll talk about that. But if it's really dark, maybe you lost the effect. But if it's shade of gray, still fair game.
And I think what's important, we don't use the CTP to exclude patient. I think it's really helpful for MEVO. And I think, part of us, a lot of time that you bring the patient no matter what, and you feel like you're losing time getting the rest of the images, but it's really hard. You would need somebody, a provider, looking at this patient and this CT in real time all the time, and just bring the patient if you don't need the CTP. But I think what has been helpful in stroke is to kind of stop thinking and just protocolize things and go quickly. So it's hard to, I don't know, it's hard for us to see how we could get rid of the CTP because it's still helpful in some situation without having someone who's just sitting there and looking at all those images in real time.
Hi, Nicole.
Hey, everyone, how are you?
So we have the distinct honor of having Nicole Cancellieri. Did I say it right?
You did, yes, thank you.
Dr. Pereira's right wing in Toronto. Nicole is going to talk to us about robotics for acute stroke intervention. She has been instrumental on the Toronto epicenter of this. All roads in robotics lead to Toronto. So, and the Canadian geography and weather is phenomenal for this to happen. So I'm sure this is going to happen first in Canada. So Nicole, please.
Sure, thank you for the introduction, and thank you for the invitation to be here. I'm very excited to share our journey on robotics with you, and also get you excited about the next steps in the future, which will be remote. So I'll just share my screen. Can you see my slides here?
Yes.
Great. Okay, so are we ready for remote neuroendovascular procedures? Maybe I would just ask everyone in the group, what is everyone's thought on this? Maybe you can take a poll of who thinks this is possible and who thinks this maybe is something in the next decade that won't be coming soon.
So raise your hand if you think it's possible. Raise your hand if you think it's crazy. Okay, majority, said it's possible, nobody said it's crazy, so.
Okay, so I have a good group, great.
And everybody's thinking, please do first in Canada.
Okay, great. Well, as you know, with the explosion of technology in the last decade, we've had an amazing improvement in the capabilities of what robots can do. We have, robots that can do amazing tasks. They can do amazing things. These are some of the robots that exist today. And now even like the Tesla factory, even, cars can be completely automated, almost 95% automated to make a car nowadays. So how about the field of neurointervention? Well, robotics in our field has been around for quite a few years. Our team performed the first neurointervention on an aneurysm, a patient for an aneurysm back in November of 2019. So this was published on the cover of JNIS. But that journey to get there took some time. So this is a picture of the robot that was used back then. This is the Corindus GRX. Has a one-time use cassette with a linear drive, rotational drive, and can control a microcatheter and a micro wire. There's a touch screen that lets communication happen from the bedside team to the operator. And this is what it looked like set up in the room. So many of you are probably familiar with this or have seen this or at least heard about it, as there was also the global trial as well, which many centers across Europe, including ours in Canada, were enrolling in. And this is a picture of what the cockpit looked like, with some different, handles and a touch screen to control the different movements of the robot. So that journey to get to that, first in human back in 2019 took a lot of research, a lot of backup, a lot of development. So we had a preclinical phase that started in early 2018, working on animal models like pigs to do various procedures, both stroke and aneurysm. And then after installing the robot in Toronto in early 2019, we did over 200 experiments on silicone models, just really testing the, the applicability in different types of anatomies. And then we expanded into the clinical phase in end of 2019 through 2020 and 2021, which was a local study, feasibility study, as well as the GRX international trial, throughout those years. And so since then, we have been working on the development of the remote technology because we saw a huge value in the local practice. And so just to show you some of the images and videos from our lab, this is us set up with the GRX in the angio suite. We tested every single device, catheter, guide, wire, every implant that we had available in Canada, including web, 6 different kinds of flow diverters from Stryker, Medtronic, all the companies, stents and coils. And we not only tested them we tried to use a range of models because we know the complexities of a distal aneurysm like an MCR and ACOM have different, for example, length, restrictions as well as slack management. So the difficulty in, for example, posterior circulation versus anterior proximal and distal is different. So we did a huge range and we published this experience as well. There were a number of different papers that came out, not just from our group, but many other groups as well, utilizing this GRX system in different cases, including carotid artery stenting in the US. And so here are the results from the GRX feasibility study. So 117 patients were enrolled with a primary effectiveness of 94% and a primary safety endpoint of 3.4%, which was similar to other trials in aneurysm treatment that had been done before. So, we saw that this was a safe and effective way to treat aneurysms. So now, from that experience, we are trying to quantify in our research, how can the value of robotics, really be quantified, and what did we learn? So we felt that using the system and Vitor, Dr. Ferrer, who you all know, felt that it was very precise. So this is him operating here on a model during one of the SLICE congresses, placing an Atlas device and doing the stent-assisted coiling of this basal tip aneurysm. And so you know, how do you quantify that precision and show people that it's precise? And also, we felt because of that precision, that it was safe. So some of our, you know, experiences, for example, with fellows who were using the robotic system during cases, you know, we saw that they were more precise, but also, you know, they were able to control the devices much better and perform at the level of a senior staff member. So we decided to take this experience and try and recreate in a research lab environment the same sort of setup and quantify really that precision. So we had this study which was run by Dr. Charbonnier, which is one of our research fellows who was visiting us for 1 year from Besançon, France. And we used a Mentis simulator to try and compare the precision between you know, just a manual operation and the robotic operation. So all physicians would repeat procedures both manually and robotically. And our hypothesis was that we would see that there was more control and improved device navigation and deployment with the robot, safer navigation, and less dangerous maneuvers, like, for example, entering a perforating branch or, for example, dissection risks. And so we recorded all of these procedures and then took the metrics from the Mentis simulator and compared all of the statistics, including how much, you know, translation, rotation of devices were used. And if we compare the different cases, so we took the fellows and put them in the low experience category, and our staff put them in the high experience category, and we saw that we separated the cases based on difficulty, so we have easy, medium, and hard. And what you see when you compare manual versus robotic in each of these categories is that the robot didn't really add much value in the easier cases. So these would be cases straightforward, not a lot of tortuosity, proximal ICA. If you look at a medium difficulty case, now you see that the fellows, when we're looking at micro-wire translation, so this is the amount of translation they needed to do to complete the task, they were significantly almost needed twice as much translation to achieve the task than they did with the robot. But there wasn't a significant difference between the staff in the manual versus robotic. But now when we move into the difficult cases, we see that both the high and low experience operators perform better, more precisely with the robot. So this shows that not only is there a value for all physicians, perhaps in a more difficult case, but that it may help, you know, early career operators perform at the level of an advanced operator in medium difficulty cases. So are we ready for remote robotic stroke therapy? That's the exciting question that everyone, you know, asks. When we think about robotics, everyone, you know, is thinking about remote. And so we decided to write this commentary paper a couple of years ago to talk about all of the things that we know will be challenges. And ahead of all the clinical robots that we know are being developed for stroke, we wanted to tackle some of these questions and issues ahead of, you know, that clinical phase. So one thing that's important to understand is where should we put these centers, right? Which sites should we select, and how do we prepare those sites and train them? What kind of local infrastructure do we need? Of course, we need an X-ray system and technologists. You probably want to have a, you know, highly trained or a center that's doing TPA with stroke neurology support, et cetera, et cetera. And then also from the procedural perspective, what are some challenges we may reach? So we need a telepresence system. We need to communicate between the two centers. I'm sure a lot of you in the audience have done proctoring before or online using different systems. And when the internet goes down, that's a big challenge. How do you manage that? If you're in two different sites, the operator and the bedside team, who's controlling the imaging, the angiographic imaging, you know, how are you communicating to the technologist or the local team about your working projections or what you need? And as well, the robotic system itself, we know that there are various challenges with the, you know, the GRX system, not having enough travel length, not having, you know, enough control of all the triaxial, like all the catheters and wires. And then of course the connectivity, which, you know, if we don't have a good connection, you can have the best robot, you can have full control of the X-ray system, have all these beautiful cameras, headsets, have your perfect site with your local team, everything's perfect, and then if your internet goes down, what are you gonna do? Or if you're in a very remote area, you know, in northern Canada or, you know, in the rural areas, how will you manage that? So these were some of the things we wanted to tackle, and we thought connectivity was something that was being overlooked, and we decided to dive deeper into that. So remote procedures are nothing new. Back in 2001, you may know of the Lindbergh operation, where a physician from New York controlled the Zeus robot to perform a 45-minute procedure, cholecystectomy, on a 60 or 8-year-old patient in Strasbourg, France. So it has been done before, but why aren't we doing cholecystectomies today, you know, remotely across the Atlantic, like he had done back in 2001? Probably because these procedures, maybe the patient can wait, or they can withstand a transfer. You know, I think with stroke, we are in a unique situation where patients can't wait, patients can't be transferred, and for a lot of areas like in Canada, there are no expertise close by. Your closest CBT center could be hours away. So it kind of sets up, I think, a perfect setup and a need for this type of treatment. So if we look at the map of Ontario, the province that we live in down here in Toronto, you can see the purple marker. So this is the map of Ontario, and the centers that are in orange and yellow are the areas which take more than 2.5 or 5 hours to reach an EVT center. So there's only 11 EVT centers of more than 380 hospitals in our province. So this is a big problem for us. Our transfer times are huge. More than 50% of our cases for stroke are transfers, and a lot of the time when they arrive, it's too late. And we're in a downtown core. Imagine as we move north in some of these other centers. So more than 75% of Ontario's population does not have good access to stroke care. And so this is where our dream or our goal to implement these remote centers throughout Ontario comes from. And also, you know, Canada is a single payer system. So the government actually, patients don't pay for any procedures here in Canada. So this also is a huge incentive for our government to support as well, because it has a huge cost savings, which I'll talk about later, for the entire network. So we pitched this idea a couple of years ago at the Angels Den competition. This is a Canadian competition similar to Dragon's Den or Shark Tank, where you pitch your idea and there's a celebrity judges as well as scientific judges that choose a project, and our team won. So this was really exciting. And with that funding, we were able to start our remote robotic research center at St. Michael's. And we were able to actually build a hybrid OR, which you can see here, and there is also an extended control room for remote, procedures as well, which we established. We were also able to recruit an amazing team that is a mix of mechatronics engineers as well as interventional fellows from different backgrounds, including neurology, neuroradiology, and neurosurgery, and also recruit support with our research assistant, Greta. And so we have, with this team, built a robot just for doing the connectivity testing that I told you about, ahead of any kind of clinical robot. So Chronos is the continuum robot for neuroendovascular surgery, and it's a co-supervised project with Dr. Bergner Kars from the Continuum Robotics Lab at the University of Toronto. And basically, Chronos can control the intermediate catheter, the micro catheter, as well as the guide wire. It's interchangeable also with diagnostic catheters, guide catheters, etc. So we can basically do the majority of the procedure, and we are using it right now in a simulated environment. And we also decided to call it Chronos because Chronos, as you may know, is the god of time. So we hope to save time and brain with the research that comes from Chronos. So here at St. Michael's, we have a research institute, which is connected to the hospital by this bridge. So it's across the street. And so a lot of our experiments happen between these two centers. So you can see Dr. Consoli, one of our research fellows that was with us last year, operating from the Lika Shane Research Tower. And in the OR at St. Michael's, we have our silicone model set up with Chronos on the table, and we were able to do some simulations. So here you can see navigation of the wire in the arch to catheterize the vessels. You can see the torque here and the translation, and this is all done with a keypad. So again, not a robot we would ever want to use on a patient, but in a sort of research setup, this allowed us to do a lot of testing and over the network. So this robot is controlled, it's coded in a real-time system, and it's controlled over an internet network. And so some of the important network parameters to understand can be used in sort of a analogous synonym to a pipe. So we have data that goes into a pipe, which would be like your water. And sometimes if you have, for example, a leak in the pipe, that could be, cause a loss of water. We would call this package loss if we were talking about data transfer. And then the water that makes it out on the other side of the pipe would be what we would call a throughput. The time that it would take from the water to get from the front to the beginning to the end of the pipe would be your latency, so the delay in time. And the bandwidth would be like the size of the pipe. So the bigger the pipe, the more water you can put in it. And so what your effective latency or what your effective result on the other side is a combination of these different factors. If you have a really small pipe, you're likely to have, more problems, more issues with all the other connectivics. So we did 3 main studies to study each of these different parameters. The first one, we wanted to understand how minimal of a bandwidth we would need based on the image resolution. So you can imagine operating a robot is very, binary. It's simple commands. But if your imaging is delayed and you're operating the robot at a certain speed, but your image feedback is slow, you may be navigating and causing, for example, a dissection or rupture because you're not seeing what you're doing. So this is very important. And so we wanted to minimize the amount of information, but obviously we need to make sure that that's safe. So we took procedures and we changed the resolution, and we had physicians watch an entire procedure. And at different moments of the procedure, for example, extracranial navigation versus intracranial navigation, we had them score what safety level or what minimum resolution they were comfortable with. So we went from 1080p all the way down to 270p. And we were able to show that this was eight neurointerventionists that did the study. We were able to show that 100% of the time physicians were comfortable with a 1080p resolution. So this is a savings of, upwards of 4 to 10 times, depending on the size of your screen, of bandwidth that is required compared to the 4K monitors that we use in the Angio Suite. So this was a great result. And then we decided to do a simulated latency study. So this study was run by Dr. Consoli and Charbonnier, our 2 fellows from France. And we had an engineer that coded a delay. So you can see that the 2 operators are standing in front of the Angio Suite and they're using the screen, but on the back side of the screen, we actually had the real screen, which was then going through a computer, which manipulated a latency that was then shown onto the big, large display or the Flex Vision monitor for the operators. And so they were blinded to what the latencies were, and the latency could change at any moment during the case. So they weren't sure what it was, and they had to fill out a qualitative score to say how comfortable they were in each of those moments of the procedure. So just to show you an example, this is what it looks like. On the left side, you have the real monitor. On the right side, you have the delayed simulated case. So you see how we had a bit of a jump there. Sometimes you don't know if you're building up slack. You don't know, you may think you're building up slack, but actually it's a latency and you're not seeing. So we get these dangerous uncontrolled movements that I had mentioned earlier. So here the task was to place the stent, which you see is placed, and then to enter the aneurysm to coil. You see there's some resistance and the physician is pushing, doesn't realize, and perforates the aneurysm. So these are examples of dangerous uncontrolled movements. Because we're in a simulated environment with Mentis, we can safely do these kinds of tests and show the importance of having a low latency. So we determined that our acceptable latency for neurointerventions is between 100 and 250 milliseconds, depending on the moment of procedure. and also depending on the type of case. So aneurysms, we were a little bit more, strict, and stroke, we were a little bit more tolerant on the latencies. As you can probably imagine, the precision required for placing a stent, compared to maybe the precision for an aspiration. And if we compare this to the cardiology studies that were done on remote and latency testing, they had set tolerable latencies of 400 milliseconds. So this is why we thought it was important to apply this in neuro. I think we deal with a lot more slack. There are a lot different, more tortuosity, more challenges that we see in neuro, and so these thresholds were a lot lower than what was seen with our colleagues in cardiology. The third study was another simulated study with Mentis. You can see here an example of a 7% package loss during the case. So we did combinations of jitter, package loss, and bandwidth changes, ranging from 5 to 100 milliseconds, 0 to 7%, and 200 megabits per second to a gigabit per second. And we were able to, again, basically draw the thresholds of what was acceptable during these procedures. And so here's a picture of Vitor in the Liechtenstein building, the research tower, performing a remote experiment on the Mentis, which was located on the hospital side. And you can see here all the different network trials that throughout the case, how there were combinations of different parameters. And these are the results from that study. So again, we separated the fellows from the staff, and we looked at what their tolerances were. And we saw that the most significant parameter in impacting the comfort level and the safety of the operators was package loss. So very important to have a high bandwidth and to reduce the amount of package loss, and of course the amount of jitter. And we saw that the more experience that you had as an operator, the more comfortable you were. So this is an alluvial plot. You can see all the different trials with the combinations of network factors you see on the left side here. And if you follow the colors, you see that the junior or less experienced operators were more likely to score lower on comfort levels, more scores on 1 and 2, as opposed to the staff who had more scores in 2 and 3, meaning that they were a little more tolerant to these changes, which is something you would expect probably, for early career physicians. So what are the next steps? To move now from this research phase into a clinical phase, we need to repeat a lot of these tests with the clinical robots and do feasibility testing. So as I had mentioned previously, some of the challenges with the GRX system was the travel length, and the lack of a triaxial control. We were only able to control 1 microcatheter and 1 wire. Although we were able to do stroke thrombectomies in models, we didn't think that, this was a reasonable thing to do clinically, because you would still have to place the catheter manually in the neck. And, if you were to train a site to place the catheter in the neck, who's to say you couldn't train them to, aspirate or deploy a stent retriever, because often the main challenge is, the navigation of the arch. So I like to show this video, and Vitor likes to show this video because this is his son, Pedro. And during COVID, we did a little field trip for his family. So the kids came and we taught them how to do a stroke thrombectomy in a model. So this is Pedro doing a stroke thrombectomy with the GRX system back in 2020.
Backward, faster, backward, faster. Okay, now forward, faster. Now forward.
I'm not sure if the audio is coming through, but he's basically coaching him saying, push forward, pull back. So he has a stent retriever placed, and he's pulling back stent retriever. So, this shows that it is possible, but we really thought it would be good to wait for the full systems that can go all the way from the groin to the head to just have the safest and best system for, doing these procedures. And so the robotic systems of today, there's more than 20 companies developing robots that can do full procedures from the groin to the head. They have 3 or tri or quadaxial control, being able to control a catheter. So Here you can see navigation in a model from the brain sheath, going all the way up to the head. So this is the next version of the, the Siemens, or previously called Corindus system, and there's many other companies developing that as well. Also on the next steps for us in Canada, we are looking at remote site selection. So we have done a cross Ontario analysis where we took all centers with more than 10,000 patients, cross-referenced them with the EVT centers and then centers that had cardiac monoplane, because we figured if there was PCI services available, you have potentially someone who could get access at the groin, technologists to operate the equipment, and as well, we cross-referenced it with centers that were giving TPA, so you had the stroke neurology and the radiology sort of workflows to diagnose the stroke from the CT scan. And so we did an analysis and calculated the minutes of brain loss per year based on the number of estimated EVTs these centers would get, together with the distance it would take to transfer that patient to the closest EVT center. And so our top two results were Barrie. This is a city about an hour and a half north of Toronto. Although they're not so far from Toronto, the transfer times in real life do take upwards of 3 hours often. And they have a larger catchment area of patients. So we estimate a cost savings based on this paper published by Coons, savings of up to $2.6 million with implementation of a robot in the center. And then we have another center in the north called Sault Ste. Marie. This is 700 kilometers away. Takes them various hours to get to the nearest EVT center. And although maybe the volumes are less, the impact could be greater in the center. So we reached out to a number of centers on this list and are already sort of planning ahead for establishing these centers, working with the government, working also to have this established in Ontario. As you can imagine, a patient with an MRS 4 or 5 could, be a burden on the healthcare system. This longer ICU times, rehabilitation costs, which again in Canada is completely paid by the government. No payments are made by the patients themselves. So these numbers are very, very, very modest on the very low end. We think that these can go significantly up from here. And so we've started doing connectivity testing between various hospitals, and to our happiness, I guess, surprise and happiness, our latencies and our mean round trip times are very low. So with hospitals that are, for example, within the same city, we've had latencies of 8 milliseconds and maximums of, or averages of 32 milliseconds with centers that are hundreds of kilometers away. So very good results with 0 episodes of lost connection. So we're doing a lot of these tests, getting ready for moving into the clinical phase. So I will stop there and leave you on a bit of a cliffhanger because can't really tell you more, but I think, I would encourage you to have an open mind about this. I think it's very exciting. I think there's a lot of potential. I think most of you put your hand up, so I guess I don't have to convince many of you in the group, but this was a slide presented by Fred Moll at a conference recently that we really loved. It's the 4 stages of acceptance. The first is abject horror. People look at you and say, are you out of your mind, right? There was a lot of criticism when robotics was starting back in 2018, people saying that, this wouldn't be possible. Then there's the next phase, which is the swift enunciation, like, oh, it's not a bad idea, but it's very dangerous. Are you sure? Like, that sort of the questioning of that. The next phase is the begrudging acceptance. People saying, oh yeah, there might be limited applications. And then the final phase is ringing endorsement. It's where people are all of a sudden saying, oh yeah, I proposed this 10 years ago. So maybe some of you have similar stories with the stroke, pre and post 2015, but we think this will be similar for robotics. And examples in history where people said no way it would be possible, right? Man landing on the moon. People were very skeptical of self-driving cars. We see them all around today. AI in our daily lives, everyone I think has seen or used ChatGPT. We see how much value it can bring and efficiency. And so we hope to be the final story on proving people wrong with robotics. And so with that, I'll just say thank you and happy to take any questions.
Thank you, Nicole. Very, very nice. Any questions for Nicole, guys?
Nicole, Eric Soajo here, merci beaucoup, it was fantastic. So I am kind of in between, I'm ringing an endorsement for Canada. And I think it's the coolest thing and the greatest idea for my own country. But I'm quite skeptical for the rest of the world, for a couple of reasons. First, United States, for many, many reasons, it's really hard to believe that anytime soon this would be something accepted, even in areas that are underserved for various reasons, lack of alignment and all this. And the other sad part is that all the other part of the world that would benefit tremendously from that, mostly in the current context where, you know, helping our neighbor doesn't seem a big trendy those days. It's hard, like for example, Africa, I mean, obviously this kind of technology would be fantastic in all those countries that are underserved. But it's really hard to think that the alignment will be there for this company to make those investment and all this. So again, extremely excited for Canada, but the rest of the world and the applicability worldwide, I'm a little bit more skeptical.
Yeah, I think that's a really, great point and very logical. I mean, there's centers today that still don't have stroke thrombectomy, right? Like Africa, that just not able to even afford the devices, not to mention having a remote robot. So this is a global problem, and I commend Sheila Martins and the World Stroke Organization for all the work they do. I volunteer with them, helping train centers across the world for, technical skills for stroke thrombectomy. But you're right, there are some places that it's just not going to be possible, and that's unfortunate. But what our goal is with this is to show such an impact, like the trials of 2015, that it will be unethical at some point to not have it. If it's so effective and it's so helpful, the government is not going to be able to say no, because you're going to help areas that really need it. Of course, it's probably going to start in more developed countries like North America, but I'm sure we've done analysis in the US. There's many centers, many areas of different, states that don't have good access to stroke care. So I think there will be value. Hopefully Canada will set an example that can be adopted in other countries as well.
Yeah, I have a question for the 51st state. That was a joke.
Yeah.
So Nicole, this is Ajay. Three quick questions for hello. So one thing is, how have you solved the injection of contrast during the intervention? So intermittent injections. That was one question. The second thing is, are your future plans if in a remote area there's a complication and there's no expert there? How would you address it? I mean, self-driving car is a good example. Crash, what do you do? Is there a safety net built in? And the third question was legality. Is it the robot company? Is it the hospital, the doctor, or who is liable if something goes wrong?
Yes, very, very good and very important questions. I think on the last one, the legality, that's probably one of the more difficult ones, but I think it's the same thing if you look at aviation. A lot of these planes are flown completely automated, but you still have a pilot, that is in the seat. I think it's the same, like the operator is still going to be liable, but we're sort of in an advantage where for stroke, we've seen the worst thing to do is do nothing, right? We did the late time window trials, we did the large core trials, and we're seeing that all of the patients are benefiting, and the potential to make a patient worse is limited. So I think we're going to show a value. I think that will, stand strong. The first question regarding contrast injection. So different, companies, different robotic systems have different integration. You can imagine companies that have robots owned by the imaging companies have a higher chance or have the ability to integrate everything more smoothly. So integrating the operator's ability to control the X-ray equipment as well as contrast injections is something that can be possible, but even externally, it can be possible as well. Alternatively, there is training of the technologist or the local most responsible physician. I think every hospital, every setup can be different, who can do the puncture, who will support on the bedside. But yeah, I think either through communication and injections or actual control of the pump by the operator are both setups that will be possible. And your second question, if you could remind me. I think maybe I might have answered it.
Oh, and you, Nicole, sorry, I was thinking of the. So, if something goes sideways, you will train the staff that's present, to basically.
Oh, yes.
Be educated, to communicate with the mothership, like, is that the concept?
Yes, so the idea is if something goes wrong, you would then transfer them to the, the closest CBT center, to manage that patient, what would have been done otherwise, yeah. And, what are your thoughts on that? As far as, do you think that it's worth treating the patient, saving, for example, for some of our centers, between 3 and 5 hours, attempting, and then if not, there's potentially still the option to transfer. What are your thoughts on that?
I'm a believer in robotics. The car was a good start, but we have hiccups, as you know, there's a lot of problems with that. But truly, yesterday I landed in Jacksonville at the airport and I didn't see anybody but 2 robots cleaning the whole floor. And I was very impressed. I have to say, I've seen a robot playing violinist better than definitely me. Toyota, and that was 15 years ago. My only concern is similar to what Eric was saying. Are we here battling the race between neuroprotective agents, and there are some that are very promising, oxygen delivery, all that, and transferring to mothership, like Dr. Rebo said, with a lot of experience, with 500 cases, 600 cases, excellent staff, and the robot will be more like in the cath lab. I know I'm back pain from all the years. For me to sit in a room and do remotely these things is amazingly valuable already. I think there will be baby steps. Remote to do from one place to the other. In Canada, of course, it's needed, I think. But I think neuroprotective agents will probably beat the technology for robotics. It gives us more window to bring the patient to the mothership and get it done there. So I'm a little bit open to robot, but I think there's so much competition and race going on between neuroprotection and doing these cases alone. That will be a challenge, I think.
Yes, we accept the challenge. We look forward to it.
Draw that matter from analytics like with DNAs and bone field brand. I think it'll be interesting. Hope they put us throw back in our business. Everything will be IVTA again, and Dr. Jimson can take over.
Get our evenings back, 2 a.m.'s back.
Anything else for your call, guys? I think we're gonna conclude the call. Thank you so much. Always. Tell Victor we appreciate his efforts as well, and I will see you soon.
Sounds great. Will do. Bye, everyone. Thank you.
Do we have a last graphic?
Yes.
Are you gonna do the yesterday there was a question that Wendy was biased in this selection. No, that's Dr. Walker will pick it's over here. Looked like Wendy knew was gonna be there.
Rosemary Wilson.
Rosemary Wilson.
Awesome.
Thank you. I'm also smiling, even though I'm not. Thank you.
Thank you to Wendy, Chris, and everyone involved in making this happen, so thank you very much.
So coordinators and Suzanne, our stroke educator, for all their hard work, especially in Abby's absence this year. They had to pick up a lot of extra slack, and so we're really appreciative of your hard work and dedication.
On a great year, guys, thank you.
Okay, Chris, are you there? You can come on screen if you want. Like I said, unless everyone just took off.